an ENT consultant from Indraprastha Apollo Hospital, Delhi. And first of all, I would like to thank a few people for this masterclass. Thank you, Dr. Sharmila. Thank you, Dr. Renuka Bradu. Thank you, Todd. Thank you all for organizing this masterclass. Hope it benefits a lot of you. And first, just two lines, to stand in solidarity with all the doctors who are now protesting. The central government is putting some pressure, asking the rallies to stop and all that. But I don't think we should give up the pressure. We should keep putting pressure on everyone so that at least now the law gets enforced. So thank you all. Regards. Have a nice day. Hope you benefit.
Good morning, everyone. I'm Dr. Sharmila Sondi, the co-founder and vice president of WAI, and I'm honored to welcome you to the first WAOI Surgery Masterclass, a milestone for WAI, Women's Association of Otolaryngologists of India, introducing a unique educational experience for skill development in surgery to support the interests of our women otolaryngologists. Our WAI journey began with two people, Dr. Kalpana Nagpal and myself, with a dream, and it has come true after 4 years with more than 1,900 members in 2 WhatsApp groups. WAI has evolved into a very interactive networking platform for mentoring, exchange of ideas, and skill development, and we hope to grow in stature globally in the future. I have had a long association with Dr. Renuka Bradu, a world-renowned ENT surgeon and an excellent teacher and mentor who needs no introduction. I would like to express my thanks to Dr. Renuka for organizing the program with her team of doctors from Mumbai, Dr. Sujata, Dr. Sangeeta, Dr. Anagha, and Dr. Shivali. This masterclass is more than just a learning opportunity. It is a celebration of expertise, innovation, and the spirit of collaboration. As we delve into the comprehensive range of topics covering surgical procedures of the nose, ear, and airway, we are reminded of the importance of continuous learning and the sharing of knowledge, which is the cornerstone of medical advancement. The breadth of topics covered today reflects the diversity and complexity of our field, from intricate nasal surgeries to the nuances of managing airway conditions. Each session is an opportunity to see how knowledge is applied in practical real-world scenarios. I encourage you all to engage actively, ask questions, and take full advantage of the wealth of knowledge available today. This is your chance to deepen your understanding, refine your skills, and network with peers who share your passion for otolaryngology. I'm confident that today's sessions will have a lasting impact on your professional journey. Our esteemed faculty brings together decades of experience and cutting-edge knowledge, ensuring that the discussions and presentations we will witness today are not only informative, but also transformative for our practice. The sessions have been meticulously designed to provide a well-rounded perspective that caters to both seasoned practitioners and those newer to the specialty. I would like to thank the entire team of Entodd Pharmaceuticals Limited for the invaluable support to WAI and the first WAI Surgery Masterclass. We deeply appreciate their commitment, collaboration, and contribution to WAI for advancing education in otolaryngology to aid skills enhancement for women otolaryngologists. It is my pleasure to introduce our first speaker for today, Dr. Renuka Bradu, Professor and Head of the Department of ENT at LTMMC and GH Mumbai, renowned for pioneering surgical techniques and setting new benchmarks in otolaryngology. She will share insights that have been honed over years of dedication and innovative practice. This is a rare opportunity to hear directly from someone who has contributed significantly to the field with an unwavering commitment to excellence. She is the first surgeon in India to undertake endoscopic excision of juvenile nasopharyngeal angiofibroma and has pioneered the push-pull approach and 4-port approach for very large tumors and the angiofibroma grid. She is the author of Anatomical Principles of Endoscopic Sinus Surgery, a step-by-step approach, and has 14 textbook chapters and numerous peer-reviewed publications. She was awarded the International Feimer Fellowship and has a keen interest in medical teaching. She will be speaking today on stepping stone surgery for extensive nasal polyposis. Over to you, Dr. Renuka.
Thank you so much. I'd like to initially Can you see me?
Yes.
So at the initial thing, I would like to congratulate Dr. Sharmila Sondhi and Dr. Kalpana Nagpal for putting together and spearheading such a wonderful initiative. And I'm very, very proud and happy to be part of WAOI.
Thank you, ma'am.
You're welcome. I feel very strongly that we needed a platform for women to interact, but I also hope that all the women will make sure that they get onto the national platform of AOI as well, and that they do not only limit their ambitions to WAOI. At the outset, I'd like to request for a 1 minute silence to honor the lady doctor from Calcutta, for whom we are all working hard to get justice. May I request everyone to observe a minute of silence. Thank you, everyone. So I'm going to talk on stepping stone surgery. And this talk is targeted for the trainee residents, as well as to those who are in the first 3 to 5 years of their practice as endoscopic surgeons. When I was starting and learning endoscopic sinus surgery myself, I remember being overwhelmed and daunted by cases where the polyps were so extensive that they were coming up to the nasal vestibule, and no landmarks could be seen because of all these polyps. To add to the problem, very often these were revision cases where the landmarks, the standard landmarks that we use in FES surgery, were not there. Someone might have trimmed off the middle turbinate, removed the axilla. The uncinate may be removed or maybe polypoidal, just as the middle turbinate could be polypoidal and look just like a polyp. And thirdly, a lot of these cases which we get as revision would be extensive cases where the lamina papyrica is eroded, where the skull base is eroded. And therefore, the condition was that as a young surgeon, I was always worried about entering the orbit and the skull base. And therefore, very often we left behind some amount of disease along the lamina papyrica or along the skull base because we were not confident enough about removing everything without causing a complication. So I'm going to talk about this video. The whole idea is to simplify matters. The simplest form of painting is painting by numbers. You see the number and you put the paint. So think of this stepping stone surgery as operating by numbers. Now, let me give you a metaphor. If you have to cross a shallow stream, all you will do is just walk across it, wade across it through the water. And this is similar to doing basic standard FES in a primary case. That means you will find the uncinate, you will remove the uncinate, uncinectomy, then you will open the maxillary sinus, then anterior, posterior, ethmoid, sphenoid. You may do the frontal before you intact bulla technique. So this is standard basic FES. But imagine if you have to cross a river full of crocodiles. Like, the case that I mentioned, a revision case with erosion of the landmarks. In such a case where you're crossing a river with crocodiles, you need a different approach, obviously, which means you can't wade across it. You would have to find stepping stones so that you don't endanger yourself. And you will have to first step on one stone, then find a second stone to step on, and so on and so forth. So also in this stepping stone surgery, we are going to find one landmark. And using that landmark, we find the second landmark and go on to the surgery like this. The attempt is to make it possible for a relatively young surgeon, and by young, I mean young in experience, a young surgeon to be able to perform this entire surgery along the lamina papyracea, along the skull base completely and safely. So that is the intention with which I've put this video together. It has a sound voiceover, but I will be stopping intermittently to just discuss some points according to what is going on the screen. So my presentation is essentially one video, which we will stop intermittently to discuss. I would be happy to answer any questions at the end of this. So I'll just share my screen with you. So what we are going to talk about is stepping stone surgery. I hope you can all see my screen. Mr. Sunil, they will be able to see my screen, right?
Yes, yes, we can see.
Okay. So I'm going to talk about stepping stone surgery. So let's take a case like this. This is a case with extensive polyps, and you can't see any landmarks. It is also a revision case which has been done by someone else. So this is a case of extensive nasal polyposis. It's a revision case, and there are no landmarks seen. We begin first by debriding the polyps along the floor of the nasal cavity at the junction of the floor and the nasal septum. Now, why we do this? We are not going looking for the middle meatus at all. We are not looking for the middle turbinate. We are not looking for any of those landmarks. We have started the surgery on the floor of the nose at the junction of the floor and the septum because that is the safest area and that there is no important structure there. And we are going to look for the first landmark that we need. I want to make it, I want to also mention that I've used landmarks which even the primary surgeon cannot remove in his surgery. So these are landmarks which can be used in revision surgery because they are generally always present even in revision surgery. So we start with a debrider along the floor and we proceed gradually posteriorly. Since there is no important structure along the floor of the nasal cavity, one can go ahead without being concerned about any damage to any important structure. As we extend the surgery posteriorly, we are now looking for our first landmark, the roof of the posterior choana. And we can now just begin to see the roof of the posterior choana coming into view. This is one landmark which cannot be removed by even the most aggressive surgeon. This is the roof of the posterior choana, and it helps give us perspective of the anterior posterior depth. So what I'm doing is I'm trying to create a landmark which is along the x-axis, which means we're actually trying to find coordinates, along x, y, and z axis. So at the moment, I've used this to find the x-axis, which means that when you have the choana, I said posterior choana, I really mean choana. When you have the roof of the choana, you can always, at any point in the surgery, go back to it to see how deep you are. So if you're deeper than the choana, that means you're in the sphenoid. If you're superficial to the choana and you're still very deep, you're in the posterior ethmoid. And if you're fairly superficial, then you know that you're in the anterior ethmoid. So you're using the choana as a landmark for depth and how deep your surgery is at a given time. The second landmark is the inferior turbinate. The attachment of the inferior turbinate is such that it first ascends up to a peak and then comes down inferiorly. And the apex is where the nasolacrimal duct is present. We now delineate the entire inferior turbinate by debriding some more polyps. So I'm not using the middle turbinate as a landmark at all at the moment. I'm using the inferior turbinate as a landmark. This is also another turbinate which is usually not removed in primary surgeries.
The third landmark is the maxillary sinus. We use a maxillary suction without the suction attached to it to open the maxillary sinus, not in the normal ostium, but just above the inferior turbinate. This prevents accidental entry into the orbit.
So we realize that the middle meatus is full of polyps and we don't know whether the uncinate is there or not. So you may not have that landmark. And therefore, for a young surgeon to find the normal ostium may be a challenge. And of course, you know that just 2 to 3 millimeters above that is the orbit. So you could, while trying to find the normal maxillosteum, actually enter the orbit. So to make sure that doesn't happen, we create an artificial opening. We create an artificial opening just above the inferior turbinate, because if you go there, there's no place you can go other than the maxillary sinus. There's no danger to the orbit. And later on in the surgery, once we see the uncinate, once we have that landmark, then we'll go for the normal ostium and then connect these two so that the normal ostium as well as this artificial ostium we've made, so that there is no recirculation of mucus.
We widen the opening of the maxillary sinus. The fourth landmark is the middle turbinate. We can now see the middle turbinate since most of the polyps along the lower half of the nasal cavity is removed. And we now need to remove the polyps in the middle meatus. We use the maxillary sinus opening as a landmark to get the perspective of medial to lateral depth, as the posterior choana gave us the perspective of anterior to posterior depth.
So this is the second axis which we are creating. So it's the y-axis we are creating so that we get another coordinate. Now, the thing I want to say here is that the maxillary sinus opening, once it is opened, the plane of the lamina papricia will be either in the same line. So the plane of the lamina papricia will be in the same line as this maxillary sinus opening. Or if there are extensive polyps, the lamina papricia may be pushed towards the orbit, in which case it will be lateral to the maxillary sinus opening. It never happens that the lamina papricia comes medial to the plane of the maxillary sinus opening. So because we know now that the lamina papricia cannot be medial to this, we know now how much laterally we can go without damaging the orbit. So let's watch what happens.
The plane of the maxillary opening is such that the lamina papricia cannot lie medial to it. So we use this plane and remove all the polyps medial to the plane of the maxillary sinus opening.
So what routinely we are taught in FES is that you must go layer by layer, remove the entire bulla, remove the entire ground lamella, look at the lamina papricia and continue layer by layer, removing all the cells. Now, for this particular kind of case, we don't do that. We just remove all the polyps in the middle meatus, which are medial to the plane of the maxillary sinus opening, which means you will leave behind cells or polyps along the lamina papricia. We are going nowhere near the skull base. And at present, we are not trying to delineate the lamina papricia or go anywhere close to it. We are just debriding all the polyps in the middle meatus, which are medial to the plane of the maxillary sinus ostium.
So we are sure that we are not going to enter the lamina papricia. The next landmark is the uncinate process. Once we have debrided the polyps in the middle meatus, we can now see the remnant of the uncinate process.
So you see that, you know, the uncinate process is polypoidal. It looks very similar to a polyp. And it's only because we've removed the polyps medial part of the middle meatus, we are now able to see that uncinate. So now that we can see this uncinate very clearly, which we will, you know, make sure that it is the uncinate by seeing its lateral attachment or seeing its attachment to the lateral nasal wall. Now that we can see it clearly, now that we can see the middle turbinate clearly, we are now going to open the normal maxillary ostium.
We can see the point of attachment of this remnant to the lateral nasal wall. And using the uncinate as a guide, we now open the normal ostium of the maxillary sinus. We connect this to the accessory ostium that we have made to avoid circus movement. We now debride off the remnant of the uncinate process. We can do this without worrying about the lamina papyracea because we have a perspective of the lateral to medial distance.
So if you pull anteriorly, you can strip mucosa. If that happens, you go posterior.
The next landmark is the axilla of the middle turbinate. We first remove a remnant of the uncinate in the uppermost part, and this is the apex of the vertical part of the uncinate process. The middle turbinate is polypoidal, and there are also polyps in the region of where the axilla of the middle turbinate would be. We skeletonize the middle turbinate by removing the polypoidal mucosa which is present around it. We also remove the polyps in the region where the axilla of the middle turbinate would be. We take care not to remove the polyps right up to the olfactory groove. Remnants of those polyps would be treated by steroid nasal sprays.
So what happens in workshops when there's an experienced faculty showing the surgery? They have a natural 3D picture in their mind, and therefore with these extensive polyps also, they can start working directly in the middle meatus. They can, skeletonize the bulla, the middle turbinate, just with actually judgment. Now, this judgment is something which comes over years, and therefore what happens very often is in the workshop, everything looks wonderfully done. But when a young surgeon tries to replicate it, it becomes difficult because he doesn't still have that judgment of where that polypoidal middle turbinate or uncinate is. So that's why I've said that you find these landmarks before you go for the middle meatus. And you don't enter the middle meatus till you have the landmark of the choana, of the maxillary sinus opening, and of the inferior turbinate.
We now open the bulla. The previous surgeon has not done too much work in the middle meatus, and the bulla is still intact. We debride the bulla and remove the polypoidal mucosa. We keep always medial to the plane of the maxillary sinus opening. We continue to use the maxillary sinus opening as a reference point so as to avoid damage to the lamina papyracea. We continue this as a reference point till such time that we can actually see the lamina papyracea.
So we are going from the anterior ethmoids through the ground lamella into the posterior ethmoids, everything medial to the plane of the maxillary sinus opening, which means, like I said, you are still leaving behind polyps and septae along the lamina papyracea, but you're staying away from the lamina papyracea just yet. Now, this is the other landmark which even the most aggressive surgeon can't remove, and that is the floor of the orbit or the roof of the maxillary sinus.
The next landmark is the floor of the orbit. So when the maxillary sinus has been opened widely, we can see the roof of the maxillary sinus, or what is the floor of the orbit. We now have an idea of where the orbit would lie superior inferiorly in the. So this is the roof of the maxillary sinus or the floor of the orbit, which will turn upwards to form the lamina papyracea.
So the reason we use the roof of the maxillary sinus or the floor of the orbit is we know that the orbit lies superior to that. So everything below that line, below the roof of the maxillary sinus, all that tissue can be removed very easily without worrying about entering the orbit. So what we've done now is we've created a third axis, which is the Z axis, which means now we have perception of depth, along the x-axis. We have perception of lateral to medial along the y-axis. And you have perception of superior inferior along with the z-axis. So what you're doing is you're creating coordinates during and you're operating within the safety of those coordinates. I hope I'm making sense. Please, if you have any questions at the end of thing, please do ask.
So keeping the plane of the lamina papyracea in mind, we can now remove all the cells medial to that plane. We now continue beyond the bulla to remove the remaining anti-ethmoid cells as well as go past the ground lamella to remove the posterior ethmoid cells. While we are doing this, we make sure that we stay medial to the plane of the maxillary sinus opening. It is easier.
So why are we going up to the posterior ethmoids like this medially? Is because what happens is the lamina papyracea is parallel to your scope and instruments in the anti-ethmoids. But after you go past the ground lamella, what is happening is the orbit is converging like this. The two orbits are converging like that. So the lamina papyracea in the posterior ethmoids is much more easily seen than is seen in the anti-ethmoids. So when you open the posterior ethmoids, automatically you will start seeing the lamina
to identify the lamina papyracea in the wider posterior ethmoid cells than it is in the anti-ethmoid cells. We now come to the main landmark of the lamina papyracea. As we remove the posteriormost ethmoid cells, we can begin to see the lamina.
So that's the lamella. You see, we've not done much. As soon as we open the posterior ethmoids, remove some of the polyps in the posterior ethmoids, you can start seeing the lamina. It's much more easily seen in the posterior ethmoids.
And now we know exactly where the orbit is. It's a good idea to give warm saline washes between the surgical steps so as to keep the field clear and all the landmarks visible. We can now see the entire lamina papyracea and any polypoidal mucosa, polyps or septae along the lamina papyracea which have been left behind can now be removed with the side of the Blakesley forceps.
So we always use the side, never the tip, so that you're not accidentally entering the orbit. And now, because we have the lamina papyracea actually in vision, the rest of the polyps and septae which you had left behind anteriorly in the anti-ethmoids, etc., you can now come back following that lamina papyracea anteriorly to remove the rest which were left behind.
The next landmark is the maxillary ridge. We remove redundant mucosa close to the roof of the maxillary sinus. Sometimes there's a hallux set here which needs to be opened. This is, as we said, the roof of the maxillary sinus. That's the lamina papyracea. And the junction of the two is where the maxillary ridge is present. The 10th landmark is the posteriormost ethmoid cell. Once most of the posterior ethmoid cells have been opened, we can now see the posteriormost ethmoid cell.
So there are certain points of differentiation of the posteriormost ethmoid cell from the sphenoid. First of all, the posterior ethmoid cell is triangular and tapers away from the surgeon to a point. Secondly, it opens in a coronal plane. So you can open it in a coronal plane like this, whereas the sphenoid sinus will be opened in an oblique or axial plane. And thirdly, the floor of the posteriormost ethmoid cell, which lies, the posterior ethmoid cell lies above the level of the maxillary ridge. The sphenoid lies below the level of the maxillary ridge. And the floor of the posterior ethmoid cell is easily seen with a 0-degree endoscope. You will not be able to see the floor of the sphenoid, even if it is a very small sphenoid with the 0-degree endoscope. Let me show you that.
It lies above, that's the maxillary ridge, and the posteriormost ethmoid cell lies above the level of the maxillary ridge. It is pyramidal in shape and has three walls: lamina papyracea, the skull base, and the wall common with the sphenoid sinus, and it ends in an apex away from the operating surgeon. This is the maxillary ridge, and we open the sphenoid in an infero-medial direction at the level of the posteriormost ethmoid cell. One should usually open it with a ballpoint, and then one can widen it by opening a Blakesley forceps within the sphenoid sinus and withdrawing it by keeping it open. We can now see that the sphenoid sinus lies infero-medial to the posteriormost ethmoid cell.
And below the level of the
One can
maxillary
now
ridge.
begin to remove the edematous mucosa and the polypoidal partition between the posteriormost ethmoid cell and the sphenoid sinus.
People often ask me, how much of this septum can you remove? You can remove the entire septum till you can see the roof of the sphenoid and the lateral wall of the sphenoid. We have deliberately, in this case, we never do an intact bulla technique for the frontal sinus, because if we go for the frontal sinus opening early, then we don't have the landmarks, we don't have the lamina papyracea, we have no idea of where the orbit is, we have no idea where the medial lamella of the middle turbinate is. So if you try to do it with extensive polyps in the beginning, you will have no landmarks to open up the frontal sinus. And therefore, in these cases, we open the frontal sinus only after we've seen the skull base. So now, as you see, right, from going anterior to posterior, after I've delineated the lamina also, I still have not removed any cells along the skull base. And I'll tell you why in a little while.
Quite clearly seen here that the posteriormost ethmoid cell lies above the level of the maxillary ridge, while the sphenoid sinus lies at a level below the level of the maxillary ridge.
So you can see that the floor of the sphenoid is not seen, the floor of the
The
posterior
interior
ethmoid
of the
cell is
sphenoid
seen.
sinus can now be seen. The roof of the sphenoid is an important landmark for skeletonizing the skull base. The partition between the posteriormost ethmoid cell and the sphenoid sinus is completely removed, converting them into a single cavity. Once this is done, the roof of the sphenoid sinus can now be seen.
That's the roof.
This is the lowest part of the skull base and is used as a landmark to skeletonize the skull base.
So when we are looking for the skull base, we know what is the lowest part. So we know it. So one thing which we do is quite often, sometimes the cells are left behind along the skull base. So anything which is below the level of the roof of the sphenoid cannot be the skull base. The skull base will be at least almost a centimeter above the roof of the sphenoid sinus.
Using the roof of the sphenoid as a landmark, we can then remove all the cells along the skull base. This is the skull base coming into view. One can see the posterior ethmoid artery. It is important to sound each septa before one removes it, like so.
Always direct a forceps superolaterally.
We can now see the skeletonized skull base as well as the roof of the sphenoid.
So now that you have the landmark of the skull base, you have the landmark of the lamina papyracea, both you have reached in a different way than you would do in basic FES. Now that you have those two, the skull base and the lamina papyracea, it is much safer to open the frontal sinus now.
The frontal sinus can either be opened by the intact bulla technique or at the end as the last bit of the surgery. A Kuhn's probe is inserted into the area from very close to the middle turbinate and is moved in an anterior lateral direction. The direction is important so as to not damage the lateral lamella of the cribriform plate.
So you go close to the middle turbinate, but all your instruments are directed anterolaterally, so you don't enter the cribriform plate and you don't enter the lateral lamella of the middle turbinate.
One removes any bony partitions which are present in this area, along with any polypoidal mucosa that may be present. Since the tip of the instrument cannot be well seen, one converts to a 70-degree endoscope. And one can see that the opening of the frontal sinus can be visualized. Polypoidal mucosa around the opening of the frontal sinus is debrided with a 70 rad blade.
After the 70 rad, you can also use a 120 rad blade for removing polyps in the frontal sinus.
It is important to keep the mucosa around the opening of the frontal sinus intact, as seen here. The region can be decongested using an adrenaline patty.
So this is pure adrenaline patty.
Once the interior is well seen, one can remove the polyps within the frontal sinus using a giraffe forceps. We now see a widely patent mucosa-lined frontal sinus. It is important to also visualize the interior of the maxillary sinus with a 70-degree endoscope.
So the way to do that is to actually take the 70-degree telescope right to the posterior edge of the maxillary sinus opening. Not in the center, but right to the posterior edge. And then you don't rotate the camera, you rotate the cable, the light cable, and then you'll be able to see the maxillary sinus like this.
So that
that's
one
the
can view
zygomatic
the
recess.
entire maxillary sinus and avoid leaving behind polyps or fungal debris. The final landmark is the arch. At the end of the surgery, the operated cavity should look like the arch of a cathedral, starting from the lamina papyracea, the skull base, and the middle turbinate. With all the sinuses well marsupialized. Once more, the lamina papyracea, skull base, and middle turbinate. At the end of the surgery, always check the stability of the middle turbinate. I hope this has made you more confident about going from this to this.
Just to briefly summarize, the way one goes about it in extensive polyps is first along the floor of the nose till you find the roof of the choana. Then you delineate everything along the inferior turbinate, so the inferior turbinate is seen. Then you open the maxillary sinus just above the inferior turbinate, and you widen that so that you can see the plane of the maxillary sinus opening as well as the floor of the orbit. Then after you've seen that, you remove the uncinate, bulla, posterior ethmoids, all along the medial to the plane of the maxillary sinus opening, so that you're not going anywhere near the lamina papyracea. As you reach the posterior ethmoids, you will start seeing the lamina papyracea, and then you follow that lamina papyracea anteriorly till such time that you reach the, you removed all the cells and polyps around the lamina papyracea. We don't touch the skull base, we don't touch the frontal sinus till now. And then, of course, in the standard way of lateral approach, we open the sphenoid sinus, and there we find the roof of the sphenoid sinus, and then using that as a landmark, come and remove all the cells along the along the skull base. And once you have the entire skull base, you have the middle turbinate, and you have the lamina papyracea in view, that's when we remove the cells and the polyps along the frontal sinus and open it up. So that is the sequence you would follow. And I hope that it has become a little easier to follow these steps and do what is a complete surgery, leaving behind no cells and no polyps, and as well as with complete safety for the surgeon. For the patient. Well, yes, of course, for the surgeon as well, but definitely more for the patient. So I'm done now, Sharmila, and I'll stop screen share.
Thank you very much, Renuka. It's such a wonderful presentation, and I'm sure whether it's new trainees or experienced surgeons too, this video and your talk would be very, very useful for their surgical practice. Thank you once again.
Sharmila, there are a few questions. Should I take them now?
Yes, please do.
Okay, so I'll leave this. So someone asked me how to prevent injury to the antiethmoid artery. Very important question. I should have addressed it. First way to prevent injury is to look at the CT scan and see whether that antiethmoid artery lies low or high in the skull base. If it lies low, it also means that there is a supraorbital cell which you'll have to open. Now, when you start removing septae along the skull base, up to about 1 centimeter to 1 centimeter behind the axle of the middle turbinate, you can remove all the cells. But as you come more anteriorly, what you do is you don't catch the septae with your forceps and remove it. You start knocking on you can use a frontal sinus curette or the upward Blakesley, and you break the septae without biting them. And after you've broken the septae and you see that there's nothing else, then you can take it out one by one. If the antiethmoid, like in a significant case like allergic fungal rhinosinusitis, if you feel that the antiethmoid artery is at risk, please make sure you take consent accordingly. And there is a whole lot of things that you can do very simply to manage antiethmoid artery tears, but we can't go into it just now. I'll just mention one thing, and that is, everyone asks, what is the first thing to be done if you get an injury of the antiethmoid artery and the artery retracts into the orbit? The only first thing you do before you do anything, before you do orbital decompression, is to use the palm of your hand, not the fingers, but use the palm of the hand and press on the eyeball. So the eyeball cannot protrude out, will not proptose, and the optic nerve will not be stretched. We are trying to do nothing to the artery. We are not trying to stop the artery. The artery will stop bleeding on its own. It's a very small artery. What you're trying to do is you're trying to prevent proptosis so that the optic nerve doesn't get stretched. And therefore, the first thing you will do as soon as you see that the artery is retracted is press on the eyeball and keep it pressed till such time that you've done an orbital decompression and created a second flexible wall. And therefore, then the globe will not proptose and the optic nerve will not get stretched. So that is the first thing you should do when you have an injury of the antiethmoid artery. How do you manage excessive bleeding during FESS surgery? So first of all, you need to give maximum medical therapy. You need to make sure that you've given at least 2 weeks of antibiotics. And I usually give steroids about 10 days before and stop about 3 days before the surgery. So that is what you can do. And we use warm saline washes like I showed you. You can use patties or pieces of net cell which are soaked in. So what we have, the concentration is 30 cc of plain saline in GA or xylocaine, 4% xylocaine in local. And in that, I add 3 ampules of 1 cc of adrenaline. And so that's how you can do it. Obviously, if there's a bleeder along the skull base like the antiethmoid artery, you'll use a bipolar. If it's near the orbit, you'll use a bipolar. But otherwise, everywhere else, whether it's the sphenopalatine artery, these you can use a monopolar and cauterize. So that is the thing. Give a head high to the patient and make sure that the product of the BP and pulse is less than 6,000. So that you're keeping both the BP and the pulse rate under control. You can also give a beta blocker the previous night if you want. Also, always take the patient into the theater once this patient is well sedated, so that he doesn't have an anxiety and an increase in BP. So that's where, is the axilla trimmed while removing polyps from the frontal sinus area? We were very careful about the axilla. And I would say that if you had to choose between leaving the axilla behind and opening the frontal sinus without having difficulty, I would suggest that you keep the axilla and do not trim the axilla or, go superior to the axilla. But when it is difficult and you can't see, you can extend the axilla upwards till such time that you are able to see the frontal sinus opening. I think that's the end of the questions. Thank you once again, Dr. Sharmila and Dr. Kalpana, for this opportunity. And I'll sign off now. And the next talk will be taken by Dr. Sujata Muranjan.
Thank you, Dr. Bradu. Thank you so much. It was such a beautifully explained presentations, made so simple for the residents, and I'm sure they'll all get more confident after your presentation. Congratulations. Thank you. We always knew you're a legend, and you will remain a legend.
Thank you so much. Thank you for those very kind words. Anyway, thank you so much.
Thank you.
Yes.
Hello, can I proceed?
Yes, we can hear you, Dr. Abha. A little louder, please.
Yeah, can I proceed?
Yes, we can hear you. Please proceed.
Yeah, good morning all. I am Dr. Abha Bhatnagar. I am a treasurer and we all work as a single strong unit. I would like to thank Dr. Renuka Bradu. He is a real teacher from heart. Excellent presentation. So now I would like to invite Dr. Sujata Muranjan. Yeah, she will be speaking on difficult decision in middle ear surgery. So just a moment. Dr. Sujata Muranjan is a consultant ENT surgeon at Bombay Hospital, Breach Candy and Bhatia Hospital. She has a special interest in otology and endoscopic sinus surgery. She has been author of 5 books, chapter in Indian and foreign textbooks. She has published 14 articles in national and international journals. She has been invited as a speaker at conference and CME held at local, state, national level, as well as international conference held in Kenya, Dhaka, Nepal, Sri Lanka, and Dubai. So indeed, it is always difficult as nature has gifted us so delicate but high-tech sound conduction system. More scientifically, we have evolved so much to our requirement. So one has to weigh the risk and benefit of the one to another. Disease removal versus hearing conservative. So over to Dr. Sujata Muranjan.
Thank you very much, Dr. Abha. Am I audible?
Yes, please.
Yes.
So my topic for today's presentation is difficult decisions in middle ear surgery. And as we all know that the middle ear cleft is just a small area of a volume of just 1.4 ml. But the anatomy is very intricate and very often difficult decisions that we need to take during the course of our surgery in order to optimize and give the best results to our patients. all of us know that when we see a postoperative audiogram like this, how gratifying it is when there is a complete closure of the airborne gap in case of a preoperative conductive hearing loss. But that needn't always be the outcome. Occasionally, we are left with a persistent hearing loss and sometimes even a dreadful condition or a dreadful outcome like a sensory neural hearing loss. So today I would like to discuss the factors that contribute to us trying to achieve the best possible results following middle ear surgery. The most important factor is the type of pathology. And we all know that, for example, when we are doing an ossiculoplasty in a ear with a good middle ear space, with the tympanic membrane at its a normal level, at the level of annulus, when we reconstruct the ossicles, we are going to be able to give a good closure of the airborne gap. Vis-a-vis, if the tympanic membrane is retracted, if the middle ear space is scarred and reduced, the hearing results may not always be optimal. The other factor that the outcome depends on is the skill and the experience of the surgeon and the ability of the surgeon to take the right decision in a particular given difficult situation. Of course, we must be equipped with the right equipment and instruments. These instruments are all delicate, tend to go blunt, and we need to replace these instruments with newer, sharper instruments as we course along our practice. So let me make these points clear by citing a few difficult cases that I have encountered in my practice so far. The first is a 72-year-old female having reduced hearing since 2 years, autophony and tinnitus since few weeks. She was using bilateral hearing aids for about 1.5 years and having a problem in adjusting to the use of the hearing aids. On clinical examination, her tympanic membranes were intact bilaterally, however, immobile on Siegelization, and fluid could be seen behind the tympanic membranes. The audiogram showed a moderate to severe mixed hearing loss on the right side, whereas on the left side, there was a moderate to a profound mixed hearing loss. Impedance audiometry showed a bilateral B type of curve, and the previous surgeon to whom she had consulted had planned a myringotomy with grommet incision, a relatively simple surgery which would have given good hearing results postoperatively. However, because her chief complaints were autophony and tinnitus, an MRI brain was done to rule out any intracranial pathology. And to our surprise, it was reported by the radiologist as a bilateral suspicious cholesteatoma, and that was our first red flag. Therefore, we advise a dedicated MRI of the temporal bone, which showed disease in the epitympanum and in the mastoids bilaterally, which was iso-intense to the brain on a T1 weighted image. However, iso to hyperintense on a T2 weighted image, more importantly, with no restricted diffusion. It was contiguous with the brain parenchyma, and there was CSF fluid intensity in the middle ear and in the mastoid. So this is where we found that the brain was contiguous with the middle ear and the mastoid cavity. Following this, we ordered an HRCT temporal bone, and as expected, here we could see a bony defect along the posterior part of the tegment tympani extending into the tegment mastoidium, followed along with opacification of the middle ear and the mastoid air cell system. Our diagnosis then changed from a serous otitis media to that of a bilateral idiopathic meningoencephalocele. So let us see the surgical video of this patient. After having opened the mastoid antrum, we see the bulge of the meningocele here. Proceed to drilling and widening the antrum and exposing this meningocele. With a bipolar cautery, this meningocele is reduced. And all the subsequent steps of the surgery follow the same principles as of treating a CSF rhinorrhea, where the meningocele is reduced. This part of the brain tissue that is prolapsing into the ear is a dead brain tissue and can be safely excised. Always keep a neurosurgeon as a standby while operating on such patients. Drilling is continued so as to identify the defect along all its borders. And it is important to do this so that our repair is optimum and that we are sure that we get a watertight seal. That is the adytus being widened. And it's important to do this so as to have a good aeration of the mastoid cavity postoperatively. So that is identifying the edges of the defect inferiorly. A diamond burr is being used. And this is following cauterization and making the entire surface flat on which now would rest our repair. The neurosurgeon who was in the theater at that time advised us to use Duragen, which is artificial of closure. And we take precautions that this Duragen is inserted underlay along all the edges of the defect. Having got the first layer in place, that's the Duragen being tucked under the edges of the defect. We had decided to use a second layer that would be a layer of the tragal cartilage, that is the perichondrium being peeled off from the cartilage. And it's important to have this slightly thicker layer as the second layer in order to prevent a postoperative prolapse of the brain tissue. So that's the tragal cartilage. The sharp edges are trimmed to have rounded edges. And this tragal cartilage is then inserted into the defect. Again, taking precautions that it is inserted under the edges like an underlay along all the edges of the defect. And the third layer is that of the temporalis fascia. Now, while spreading this third layer, it is important to keep the adytus patent. As I mentioned previously, that we need to have post-op aeration of this mastoid cavity. So that's the temporalis fascia covering up this entire defect. It lies flat against the tegmen. It's adjusted so as to keep the adytus patent. This is then followed by tissue glue around the edges to strengthen the repair and to help the temporalis fascia to adhere to the underlying bone. This last layer is a layer of gel foam, following which the mastoid cavity is suctioning is done in the mastoid cavity and the wound is closed in layers. This was the preoperative CT scan, and this was the postoperative CT scan 3 years later, where we can see the repair well in place and more important. Moving to the second case, a 30-year-old female who was referred to us by the neurologist of a Bell's palsy. She had a gradually progressing facial paresis on the right side, just of a week's duration. This was accompanied by earache and postural pain of 10 days duration, reduced hearing, and I've purposely put this in inverted commas. I'll discuss this later. This was preceded by nose block, nasal discharge, and fever about 10 to 12 days prior to the onset of the facial paresis. On clinical examination, bilaterally, the tympanic membranes were intact. However, the tympanic membrane on the right side was congested and bulging, the left normal. And there was also associated tenderness of the mastoid on the right side. This was our audiogram showing a severe to mixed hearing loss at low frequencies with a moderate conductive hearing loss at high frequencies on the right side and normal hearing on the left side. So our provisional clinical diagnosis was a right acute otitis media with mastoiditis, probably the pathology pressing onto a dehiscent facial nerve, giving rise to a facial paresis. However, when the radiologist reported the MRI of the brain, though the brain MRI was normal, the radiologist also reported a heterogeneous enhancing soft tissue in the right middle ear and the mastoid cavity, involving the facial nerve, the cochlea, the vestibule, and the lateral semicircular canal. And they said this was suggestive of a cholesteatoma, and that was our red flag. So we proceeded with doing an HRCT temporal bone on this patient. And as we can see here, the middle ear and the mastoid are completely opacified with this expansile soft tissue. What else do we see here? There is a widening of the edetus. There is a fistula on the lateral semicircular canal, a fistula in the basal turn of the cochlea. There is erosion of the carotid canal in relation to the middle ear cavity anteriorly. However, the scutum is intact, and this would be the level of the brain. So here we see erosion of the basal turn of the cochlea. This soft tissue is in close juxtaposition with the tympanic segment of the facial nerve, and the ossicles are not very well delineated. Thus, our diagnosis changes from an acute otitis media to that of a congenital cholesteatoma. And having gone further into the history of the patient did complain that she had a hearing loss since her childhood, which was ignored in the past. So we proceed with this surgery, which the decision was to do a right canal wall down mastectomy. The external auditory canal is being widened. And purposefully, I'm using small birds here because I'm not very sure of the anatomy. And as I proceed and gain more confidence with the anatomy, we would be proceeding to using bigger burrs. So again, the cavity being widened. On incision of the granulation tissue in the mastoid antrum, we see epithelium lying medially. This epithelium is then traced posteriorly to reach its posterior-most extent, and the epithelium is then removed. The difference here between this case and a regular cholesteatoma is there was no continuity. There were intervening areas of intact bone, and we had to slowly and gradually get our bearings, get our landmarks, and then proceed slowly with the surgery. So that is the cholesteatoma being removed. I'm trying to sound posteriorly to see how much space we have posteriorly to complete our drilling process. So again, with a medium-sized cutting board, continue the drilling posteriorly. The granulation and epithelium is elevated from the underlying bone. And we try to trace the disease to its posterior-most extent. That is the remnant of the incus that is removed. We can see the long lenticular process necrose. That was the body of the incus. That is the posterior buttress being drilled. That is the neck of the malleus being nipped. And the head of the malleus removed. And now we see epithelium medial to the ossicles in the epitympanium. This is then gently removed with a ballpoint probe And we know now that we are going to encounter a probably dehiscent facial nerve along its horizontal segment. So we proceed with dissection very carefully, having all our landmarks in view. And this would be where the dehiscent horizontal facial would lie. Having identified that, then we can proceed more confidently now to drill and lower down the ridge in order to expose the facial recess and the sinus tympani. So this is the ridge being lowered to the level of the lateral canal, keeping in mind that there is a fistula in the lateral semicircular canal. The remnant of the tympanic membrane, though intact, we had taken the decision to excise it because we wanted to keep an open cavity, not sure of having removed all the epithelium from all the nooks and corners of the middle ear cleft. Continuing with a drilling in the master tip area. And now we've switched over to a diamond bore over here in order to smoothen out all the rough edges of the cavity and in order to saucerize the cavity. Move a little bit faster over here. That is now the disease being removed from the sinus tympani. And here now we encounter a slightly complicated anatomy. This is the dehiscent horizontal facial nerve. That would be the area of the oval window. And here we are seeing disease now superior to the nerve in between the horizontal facial nerve and the semicircular canals or the vestibule. Complete the drilling inferiorly to expose the hypotympanum and to get the floor of the external auditory canal at the same level as that of the mastoid cavity. That difficult area is left behind to be tackled at the last. So this is the horizontal facial. This is the horizontal facial, and this is the disease being removed here. Sorry, this is the horizontal facial, and this is the disease being removed here between the superior semicircular canal and the nerve. And that would be the anatomical area where we would encounter the labyrinthine part of the facial nerve. So that's gel foam. And doing this very gently under magnification. I have used the sickle, but taking care to be really very careful in this area. With my blunt ball probe, I could not get the epithelium out initially, and therefore I used a sickle. So that's the facial nerve. That's the epithelium in that tiny little area that is being removed. And finally, using a ball probe to remove the last bit of epithelium here. I'm not sure whether everything has been removed. Hence, the decision was taken to leave an open cavity. That is now the anterior epitympanum that is being exposed. That is the epithelium in the anterior epitympanum, now uncapped. And is gently dissected from the underlying bone. And is then removed. And then we took the decision to go ahead and remove even the remnant of the malleus because that was not going to serve any purpose there. So that's the last bit of epithelium from the anterior epitympanum that was removed. A temporalis fascia graft was not kept in this patient. We chose to keep the cavity open and so that it would heal by. This was the erosion in of the hypotympanum, that would be the eustachian tube area. This is the attic or the epitympanum. This is the entire dehiscent horizontal facial nerve, that would be the area of the second genu. And this would be the area of the lateral semicircular canal with the fistula. That is the tegment plate, that is the sinus plate, that is the sinodural angle, and this is the mastoid tip. 6 years later, the patient has been religiously following up with us for over 6 years, and she presented again 2 weeks later. We repeated a CT scan and we see most of the disease being excised, yet some soft tissue in this area and a little bit more soft tissue over here. So there is small soft tissue in the hypotympanum contiguously extending medially into the petrous bone. There is erosion of the posterior wall of the carotid canal, and this soft tissue is also abutting the basal turn of the cochlea. So we did MRIs of this patient. This is a T2 MRI, and this is the soft tissue we see here into the hypotympanum going medially into the petrous. This is the post-contrast axial image where we see a contrast uptake over here indicating that this and this all would be granulation tissue, whereas there is no contrast uptake over here, and this would probably be residual epithelium. And on the diffusion weighted, we see weighted images, we see an intense signal in the non-EPI diffusion weighted coronal as well as axial images, indicating that this could be now a residual cholesteatoma. Its size is about 1.1 centimeter. We have counseled the patient and explained to her the need of a revision surgery. Coming to the third pathology, that is a stapedectomy. And to quote John Shea, stapedectomy is one of the most successful operations ever devised and has stood the test of time, almost unchanged since it was first described in 1956. So this is a video clip showing how the surgery proceeds when everything goes well. An endomeatal incision is being taken. The endomeatal flap is elevated up till the fibrous annulus. The fibrous annulus is elevated from the bony sulcus. The middle mucosa is inside. One visualizes the incudo-stapedial joint. With the curette, one removes the posterior superior overhang, and it is important to remember that we need to use a sharp curette here and curette away from the facial canal. So that is curetting the PS overhang. The chorda tympani is being elevated anteriorly to get it out of the way of our surgical field. And it is in this small area that the further steps of the surgery are going to be carried out. So we need a good exposure. And what is a good exposure? The pyramid along with the stapedius tendon needs to be visualized. The entire foot plate has to be visualized along with the facial nerve. Next, we proceed towards ascertaining the fixity of the ossicles. And then proceed to dislocate the incudo-stapedial joint. This is gently dislocated with a right angle, sharp right angle pick. Proceed then to cut the stapedius tendon. Again, we require a very sharp bellows. And then proceed towards drilling of the crura with a skeeter drill. Here we've used a 0.6 millimeter skeeter, and the speed of the skeeter should not exceed 3000 revolutions per minute. Again, the skeeter burr has to be sharp. That's now the anterior crura being drilled. This is a little bit of a blind area. The suprastructure of the stapes is then removed with a crocodile forceps. Now, the way we measure the pistons is we have these pre-cut pistons of different sizes, and we pick one, most commonly either a 4.25 or a 4.5 millimeter pre-cut piston, and it is placed on the foot plate in a position such that this part has to lie at the mid-level of the incus to accommodate for the depth of the fenestratum. So that's a dummy piston being placed inside on the footplate area. And position it exactly in the anatomical position that where we would be making our subsequent fenestra. So it lies along the long process of the incus at the mid-level. And once we are sure of this length, we remove that piston and cut our of the footplate is then removed very gently with a sharp curved pick and with a skeeter drill of a speed not exceeding more than 1000 revolutions per minute. A fenestra is then made in the posterior part of the footplate. The assistant keeps a watch on the speed and we reduce the speed if the bird starts rotating faster. The controlled fenestra is then being widened. The piston has a memory and the a hole can close in size, so we need to open it once more. The piston is then held and inserted near the fenestra, but do not try to insert it into the fenestra. Sit near the fenestra and then with a sharp instrument try and manipulate it within the fenestra. Once it goes into the fenestra, it becomes very easy to put the ring around the long process of position. This ring is then crimped onto the long process of the incus. That you don't exert pressure inferiorly, rather pull, then crimp it so as to not exercise too much pressure on the open vestibule. The piston is then positioned into place and the tympanomeatal flap is then reposited. Things cannot be so smooth sailing every time. This was a difficulty that was encountered more recently, where after confirming stapedial tendon, we encountered slight difficulty in cutting the tendon. Probably the Bellucci may not have been sharp enough, so the remnant of the tendon was attempted to be cut with a sickle knife. Then proceeding with the drilling of the posterior crus with a considerable zooming into the operating field, that is the posterior crus being drilled. In this case, it was encountered that the posterior crus was pretty thick, and therefore we took the decision to proceed by then drilling the anterior crus. Again, as I mentioned previously, this becomes a relatively blind area to drill. And then come back again to the posterior crus. Again, encountering difficulty over here. So now we are inferior to the crura, between the crura and the promontory, and trying to then complete this rural
There was a lag between,
Yes,
so the
yeah.
must have slowed down.
Hello, Sunil. Others will see.
Talking her videos going. That time what you were talking, you were going with your. I was going with my.
The lag होता. Lag येत होता.
Madam, I think I realized that because you're trying to signal me, so because things were going slow, so that's why I didn't stop. What you were marking or pointing, we were not seeing. Marker of. All right, okay, I was doing it like we do for the PowerPoint.
I think are we on audio?
No, we are not connected.
Hello, can everyone hear me? We are just trying to
Yes, I can hear you.
we're trying to re-establish the connection. There seems actually we have boosted the connection specifically for this. And we are on how many GB actually? 100 Mbps. So it's usually you need about 40 Mbps, but we've made it 100 specifically for this. So in spite of that, we're getting in touch with the technical support team
Yeah, thank
to
you.
try and sort out this. Okay.
Yeah.
Sorry for the interruption. The technical team has logged in and they will try to correct it.
Meanwhile, I hope all of you have seen the news, breaking news. Another Mumbai hospital doctor from Sion Hospital injured. The attendants were drunk and they hit her badly.
Company is a company.
Yes, Dr. Sharmila. Are we
Yes.
back? Sorry for
I can see you now. Yes.
sorry for that little bit of a technical glitch. We seem to have sorted it here. I'm sharing my screen.
Yes, that's
Wonderful.
great.
Slideshow. Slideshow. How do I start the video? So not moving back, but proceeding ahead. How do I start the video here?
And Dr. Just click on the screen. You should be good to go.
Right. So I'm just going to go back just with this particular clip. I presume you have been with me previously. So
There was
this
a little lag, but it's
lag,
okay. We
yeah,
can go ahead now. Yeah.
that's what we thought. But let us proceed.
Yes.
This is another difficult situation where on attempting to cut the stapedial tendon, we were not able to cut it completely. So we used the sickle knife over here to cut the tendon. That's the zoomed in view of the foot plate, and we attempt to drill the posterior crus. Again, the steps are similar to what I was showing in my previous clip. I believe there may have been some amount of a lag between me speaking and what was being seen on the monitor. But since we all are well aware of the steps, we can proceed from here. So there was a little bit of difficulty encountered in drilling the posterior crus. It was a thicker crus. So then we proceeded in trying to drill out the anterior crus. And as I explained previously, it's a little bit of a blind area in the region of the anterior crus. Moving back again to the posterior crus area, this is the suprastructure being attempted to be fractured in order to dislocate it. Now we are working in an area between the promontory and the suprastructure of the stapes, and we are attempting to drill the posterior crus in an inferior direction between the promontory and the stapes crura. So that's the posterior crus being drilled. And then finishing off the drilling of the anterior crus. Now, in this struggle, what we realize is that the foot plate had got mobilized. Not only had it got mobilized, but it had gotten dislocated a little bit medially and luckily not subluxated fully. So hemostasis was achieved. Again, the dummy piston is being placed as in the previous surgery. It's placed on the foot plate, close to the long process of the incus, so as to ascertain the length of the foot plate, length of the piston. The dummy piston is then being removed. A tragal perichondrium is harvested. And now it is important to interpose this connective tissue between the piston and the foot plate. So that's the perichondrium being placed over this mobilized foot plate. Then the piston of the right side being placed over it. Now, since there is no fenestra, it's a little struggle to try to get the ring over the long process of the incus. It can move and you have to maneuver it gently, following which the ring is crimped. So that's the perichondrium, that's the piston over the mobilized foot plate. And this is the ring being crimped over the long process of the incus. Steroids were given intraoperatively. The tympanomeatal flap was reposited and the hearing was tested. We were fortunate that there was no vertigo and the patient was able to hear well. It is 1 month post-op now. The Renes has become positive and the Weber's has lateralized now to the opposite ear, which continues to be the diseased ear. And we have managed to get a airborne gap closure over here. So what were our learning lessons following this particular episode? Make sure that the Bellucci scissors and all the other instruments are sharp. Avoid a sickle to cut the tendon, because we then do not have a control over our next steps. Complete the drilling of the posterior crust before approaching the anterior crust so as to get a good view of the anterior crust. Remove the suprastructure only when one is sure that it has been completely detached. Never attempt to make a fenestra if there is a doubt of mobilization of the foot plate. Interpose connective tissue between the piston and the mobile foot plate. And the patient, most importantly, has to be informed about the sequence of the events. So we have informed the patient to be in touch with us and report immediately if there is an issue about the hearing going down and any giddiness happening. It's been a month post-op, keeping our fingers crossed, and hopefully all should go well with this patient. And then this patient should come back to us for the surgery of the other ear. Encountering another difficult situation in a stapedectomy surgery. How do I proceed with the video?
Doctor, just click on the video.
So a controlled fenestra being done in the foot plate, and here we see a weeping through the of the perilymph coming out into the middle ear. This was a perilymph gusher. Having said that it was a slow speed and it was not gushing out at tremendous pressure. Make sure that one is suctioning away from the fenestra that is made, and we stop here and decide not to proceed with fenestra widening, but again proceed with the same steps of keeping a perichondrium graft and a piston over the perichondrium placed on the foot plate. This presentation brings home several take-home messages. We have to think carefully if there is any discrepancy between symptoms, clinical findings, and the radiological investigations. Reports are not to be ignored if they are different from what is a diagnosis which may be provisional in our minds. We need to formulate a surgical plan prior to taking our incision. We have to remain flexible and change plans if a different or a difficult situation is encountered intraoperatively. We have to introspect about acts of omission and commission on our part, not be like a brave ostrich and say that, no, I have done everything right and nothing can go wrong from my side. We need to think, plan, introspect, and then proceed further, and importantly, to inform the patient about any untoward eventuality. This presentation will not be complete before reminding ourselves that in untoward situations, we need to not be down and beaten. We need to pick ourselves up, dust ourselves off, and get back onto the saddle, not said by me, but said by Shakira. And this would not be complete by thanking two people. One is Dr. Anand Shah, my co-consultant and consultant otologist at Bombay Hospital, where I work, and Dr. Surendra Lele, associate professor and head of MGM Medical College, Vashi. These two have been involved in helping me improve my nuances with middle ear surgery. Thank you very much.
Thank you, Dr. Sujata. It was a wonderful presentation about difficult decisions in middle ear surgery. And a high index of suspicion is definitely required to first identify and diagnose those conditions and then manage them properly for the patient.
Thank you very much. There are a couple of questions. If we have enough time, I could take them. One question is,
Please take them.
Will a mobilized foot plate remain mobilized in the future? So in this particular case, it was a situation that worked to our advantage. Not only did it get mobilized, it got medialized a little bit. So this would now stay mobile since it is not exactly at the annular rim. But yes, if the annulus of the stapedius foot plate is intact, it can get fixed in the future. We need to inform the patient of this eventuality, and we need to tell the patients to follow up, following which, if they are willing, we can proceed with a revision surgery. Do you recommend MRI temporal bone for all cholesteatoma cases? No. We do not recommend a MRI temporal bone. We do recommend a HRCT of the temporal bone, and MRI is recommended only for difficult decisions such as what I showed over here. And if it is a revision surgery and we want to determine whether the pathology is granulation, scar tissue, or epithelial tissue, it is then that we recommend an MRI. But MRI does not become the sole modality. It always has to be combined with the HRCT of the temporal bone so that we are familiar with our bony anatomy. The third question is between autologous ossicle and TORP PORP, what is our recommendation? Our recommendation is always an autologous ossicle, and we reserve the TORP and PORP for very, very few cases where a autologous ossicle may not be available. Most of the times, the malleus head may be a remnant. We can use that, reshape it, and use it for a ossicloplasty. In many of the cases, when the lenticular process and the long process of the incus is necrosed, we do have the body of the incus, and that can be used as an autologous ossicle. We feel our hearing results are better having used these autologous materials with TOPs and POPs. So if there are no more questions, I would like to thank you all for involving me today with this presentation and with this forum that we are having right now. We move on to our next speaker. Thank you very much for inviting me here to be a part of this forum.
Thank you so much, Dr. Sujata. Please join us. WI is a very...
Yes, I will. Yes, most definitely. Thank you for inviting me.
Thank you.
Moving on, I take great pleasure in inviting our next illustrious speaker, Dr. Sangeeta Varti. Madam is a consultant ENT and cochlear implant surgeon at PG Hinduja Hospital, Mahim, Mumbai. Her special interest and expertise is in cochlear implant surgery. She has been trained and mentored by Padam Shri Dr. Milind Kirtane sir. Ma'am has performed more than 500 cochlear implant surgeries, and she is a clinical expert in the National Screening Committee of ADIP. She also serves as visiting faculty at Aliyavar Jung National Institute for Speech and Hearing Disability in Mumbai. With her expertise, we want ma'am to be talking to us today about precision in cochlear implant surgery, current best practices. It's our honor that she's joining us here and sharing her expertise. It gives us great pleasure that she is a part of Women's Association of Otolaryngologists of India and lending her time and her expertise today with all of us. Welcome, ma'am. We're so happy to have you here.
Sure.
Ma'am, we can hear you.
Yeah, but I cannot share the screen.
Your screen is already shared.
I can't see my screen.
Doctor, if you can explain, yeah, that's that.
Yeah, you can see.
can
Can you see my
your
screen?
now.
Yeah, you can hear me. Yes.
Yes.
Okay. A very good morning to all of you, and it's really a great pleasure to be on this platform. And I would like to, at the outset, thank the executive team and Dr. Renuka Bradu for giving me this chance to talk on my dear subject of cochlear implant. Okay, so my talk today is on precision in cochlear implant surgery. And I've chosen this talk because last 2 decades, cochlear implant has been evolved into a minimal invasive hearing preservation technique. And you'll ask why a hearing preservation in cochlear implant? Because our evolving criteria have changed. We have started doing implants in patients with residual hearing. And so the technological advance in our electrode designs, and recently, robotics, which have gained popularity in this field, we need to know that this cochlear implant surgery needs an incredible precision. So what is an cochlear implant? It is established as the most effective surgical treatment for patients with severe to profound hearing loss who do not receive adequate benefit from acoustic amplification. And to gain an optimal benefit from the device, we need to appropriately select the recipients. We have to optimize the programming, and we should have an intense auditory therapy. Speech performances after the implants can be influenced by many factors, but I'm going to stress more on residual hearing. Pre-implant diagnostic process involves a lot of multiple steps. The patient has to go through a multiple diagnostic procedures, and this is a must, and a thorough evaluation is done to ensure that the patient is an appropriate candidate and to set up a realistic expectations. I'm not going to go into very much detail about this because our subject today is surgical technique. So, but a medical history, hearing evaluation, like when was the hearing loss, how was the hearing loss progressed, duration of hearing loss, ENT examination, most important to see the ear of a child also, because we need to see whether that there is an acute otitis media or serous otitis media before you have advised cochlear implant to the patient. Audiological evaluation, pure tone audiometry and speech audiometry, and also we should also include battery of tests like OE, BERA, impedance, ECOG, and in some patients promontory test. Of course, radiology, we need, it is like an roadmap to our surgery, HRCT temporal bones, MRI scans, and sometimes also functional MRIs are advised in some patients. Recently added are the genetic genomics for assessment of genetically associated hearing loss, psychological and cognitive evaluation, and also vestibular test. These are the pediatric selection criteria. We all know we need to we need a healthy child 12 months or older, bilateral profound hearing loss, no benefit from the hearing aids, failure to progress in speech, language, and listening development, absence of any active external and middle ear infections, no radiological contraindications to electrode insertion or receiver placement. There should be no evidence of any central auditory lesions, and of course, most important, realistic expectations by the family members. In adult selection criteria, there is no age limit as far as the patient is fit for surgery. No useful benefit from hearing aids. Audiometric thresholds that fall outside the speech range of 2 kilohertz. Preoperative test scores of less than 50% of speech recognition ability in the ear to be implanted. Or if you're doing a binaural based aided condition, it has to be less than 60%. No central component of hearing loss and realistic expectations of outcome. This is very important in adults to know what are their expectations after the cochlear implant. Now with this, we have an expanding criteria for cochlear implant. We now implant young children of less than 9 months of old. We have patients with residual hearing, so we can do a bilateral cochlear implantation or electroacoustic cochlear implantation, or patient have an asymmetric hearing loss where you can do an implant in one ear and hearing aid in another ear. So these are all hearing preservation cochlear implantation. A single-sided deafness. You have patients with malformed cochlea and inner ear malformations. You can have cochlear neoplasia, inner ear malformation like common cavity, IP2, IP3, ossified cochlea, and also cochlear nerve abnormalities are now considered in this expanding criteria. In adults, we have all atypical etiologies of sensorineural hearing loss like advanced otosclerosis, post-traumatic hearing loss, and Meniere's disease. And in also some patients of intralabyrinthine schwannomas, these patients can undergo cochlear implantation. So our selection criteria has continuously evolving, and more patients are now eligible for implantation. And so the preservation of residual hearing is now increasingly being studied. It is said that when you advance your electrode array, the cochlea sustains a trauma, and this is identified as a critical factor that can deteriorate the residual hearing. So your advancement of electrode array itself is going to cause a deterioration of hearing. So we are now going to focus upon how the electrode array which is introduced, we can minimize this trauma. Therefore, increasing attention has been focused on our surgical procedures. So this is a technique which was first proposed by Lenhard, which is called a soft surgery cochlear implantation technique in 1993. And we are following this technique, but we have to be, our goal of this technique is You have to avoid mechanical trauma to the cochlea by using your drills very judiciously. Don't use the drill with high speeds during in your when you are dealing in your touching your ossicular chain or near your round window membrane. This also limits your trauma causing because of electrode advancement. Then reduce or limit the introduction of factors like blood, bone, dust inside the inner ear because they can cause adverse intracochlear reaction. So this is our goal. And what happens because of this, besides the reaction to the implantation or opening of the cochlea, you get neuro-osteogenesis, fibrosis, and non-specific inflammatory reactions. Now, these are all the sequelae post-implantation, and they affect your cochleostomy or the round window membrane, and then you have a difficulty in sometimes in reimplantation. Fibrosis can be seen at the basal turn, also at the apical turn, and that may affect the vibration of the basilar membrane at the apical turn and affects your hearing, residual hearing. So these are the basic principles we need to follow when you're doing your cochlear implant surgery. Always do a cortical mastoid and the well prior to opening the cochleostomy. Don't just rush and do a posterior tympanotomy and cochleostomy. Bone dust and pate are thoroughly irrigated. Any entry into the cochlea like bone and dust is avoided. The electrode insertion is performed through cochleostomy or round window membrane. And if you are doing a cochleostomy, the size should be just enough to accommodate the array, and seal the cochleostomy to prevent any perilymph leakage. Avoid suctioning of this perilymph. Steroid solution is sprayed prior to opening the inner ear. Insertion should be of very little pressure. If there is a resistance, it's indicated that the electrode tip is the tip is touching the basilar membrane or osseous spiral lamella. These are the emerging concepts for basic principles. In patients who are undergoing electroacoustic stimulation, that is, they have a residual hearing, a partial electrode insertion is done in patients who have an electroacoustic stimulation. And now recently you have an intraoperative ECOG has been utilized during cochlear implant surgery, and this can provide the surgeon objective feedback during electrode insertion. Everybody now thinks about whether to do a cochleostomy or round window insertion. And there is an ongoing clinical randomized controlled trials which is still going on, which is being conducted to aim to clarify this aspect, whether a cochleostomy or round window. And it has not come to a conclusion, but it has been indicated that a round window insertion for straight arrays and a cochleostomy for perimodial arrays. So the round window approach adheres more to the soft surgical principle, but functional outcomes can be similar if cochleostomy is chosen for a selected case. These are new technique, that is robot assisted insertion systems and robotic assisted electrode insertion. So we can use robot right from doing a cortical mastoid right up to insertion of the electrode, and a robotic assisted electrode insertion seeks to limit our involuntary tremors and augment our accuracy during micro manipulation of the electrode array. Further development in this technology and more clinical evidence may convert this surgical approach into more feasible and affordable option. So till now, it is still in a trial phase. These are all pharmacological support, and all are undergoing trials except corticosteroids, which is the compound which has got an anti-inflammatory property, and it is the most studied drug which can support our cochlear implantation. So as the electrode passes through the scala tympani, it initiates a foreign body reaction. So a corticosteroid solution which is sprayed is useful for this anti-inflammatory property. Then there is a brain-derived neurotropic factors, which is BDNF neurotropin. We all know that the spiral ganglion neurons are the target of our stimulation, and this BDNF neurotropins coated with the electrode, they enhances the survival of these spiral ganglion neurons. Then there is a glial cell line-derived neurotropic factors, GDNF neurotropins. Now, these are, these factors induces the nerve axons to sprout and grow towards the electrodes to form a direct contact and close the anatomical gap between the electrode and the neuron. Then there is an insulin-like growth factors. It has got an anti-inflammatory property and it is a potential inner ear protector. Then there are other anti-diabetic drugs like pioglitazone, metformin, which are under trials, and they all are antioxidant. One more promising factor is MAPK JNK pathway inhibitor, and it has showing a very promising results in profound sensory neural hearing loss. So this is about pharmacological support which we can use if the trials are successful with our cochlear implants to preserve the residual hearing. Now we have drug-eluting electrodes. These electrodes are coated with some substances and they help to reduce fibrosis. One is a DEX-eluting electrodes, which are intensively studied to reduce the electrode insertion trauma. The first human study has been done, and this is an ongoing trial with no results available yet. Sometimes the electrodes are coated with hydrogel, and the mixture of both are implanted in a guinea pig, and they have shown to have definitely a decreased ABR thresholds. Future directions and research. Now, a nanoparticle is a new method of drug delivery. There are nanoparticles like silica and PGA nanoparticles where the drugs are loaded on these particles and they are injected inside the cochlea. Stem cells have limited benefits and there is no capacity to restore cochlear implant function yet with this stem cell research. With gene therapy, with gene sequencing methods, we can identify genes which are linked to inherited hearing loss, and a targeted gene regulation can be used as a therapeutic technique. And now last is the invisible hearing, that is totally implantable cochlear implant TICI. But we are yet in a progress to use it in one implant has been done in a human. Due to progress in battery and microphone technology, it is possible to do a totally implantable hearing system. So our conclusion is that improved electrode design, surgical advancement, and robotic instruments will make pathologic surgical procedure less traumatic and more accurate. Corticosteroids are the only compounds that are frequently used as potential agent for preservation of residual hearing, and stem cell therapy is still experimental. In nanotechnology, there is efficiency issues as well as toxicity, and stability is to be addressed in this technology. Okay, with this new information about hearing preservation, let me go to the surgical steps and video of cochlear implantation, how we do in our institution. I'm going to show a newer implants, which is a profile implant, the video on profile implant, but the steps are the same. We follow the same protocol of skin incision, raising a mucoperiosteal flap, doing a cortical mastoid, performing posterior tympanotomy, exposing the round window, drilling out the receiver well, fixation of the implant, doing the round window or cochleostomy, insertion of the electrode, doing electrophysiological testing, seeing C-arm, and closure. So let's start with, I'll first give you a detail about each step and then a 10 minutes video on the whole procedure. Okay, so this is the right ear, and we have to follow all perioperative measures like adequate cleaning, skin sterilization, and we use a sterile plastic adhesive trap to fixate the reflected pinna. Of course, an IV antibiotics and all this procedure are done. We use a post-oral incision, a small post-oral incision, but it doesn't have a curve which we use in our pathology surgery. It is more of a straight incision right from the mastoid tip to the length of the pinna. Harvesting of soft tissue. These soft tissues are used to plug the round window or cochleostomy later after the implantation is done. The next step is undermining all the edges up to the temporalis fascia level. Now you have to create a posterior superiorly based flap. This is anteriorly, posteriorly, superiorly, and inferiorly. You take an incision along the length of your pinna and an incision inferiorly. So when you are raising this incision inferiorly, you may come across mastoid emissary vein, which has to be, the bleeding from the mastoid emissary vein has to be very carefully dealt with, because in children with 1 year old, 9-month-old or 1 year old child, a little loss of bleeding also can have an adverse effect on the child. Okay, this is creating a posterior superiorly based flap. Then with a periosteum elevator, raise this flap. Now, when you're raising this flap, you see that you don't raise the flap right up to the hole of the skull, because there are chances of hematoma formation. Just adequately do so that your implant can be properly accommodated in this flap. So this is your flap posteriorly created, and you can see a template, silicone template being fixed in this flap. Now you perform a cortical mastectomy. If you want, you can line the cortical mastectomy. Now this is your at the posterior canal wall. This is at your zygomatic ridge, and this is from the mastoid tip up to this end of your zygote. So this is a triangular area which you have to drill. Now, when you are doing a cortical mastectomy, it should be wide enough so that you are able to do your posterior tympanotomy. Don't make a very small cortical mastoid, because you need sometimes your drill to go right up to, from the posterior tympanotomy right up to the round window. So you delineate your dural plate, delineate the sinus plate. You sometimes have to go beyond the sinus plate, because the sinus plate may be forward lining. So you go beyond the sinus plate and you delineate your sinodural angle, see the mastoid tip, and you drill anteriorly to see your incus. This is where your complete mastectomy is done. And one more thing is that you are not going to bevel the edges of this cavity. You need to have like a well, so that whatever electrodes are remaining array can be very well accommodated in this cavity. This is an mastoid, it's like a retractor, which was designed by Dr. M.V. Kirtani, and we call this as a K retractor. This retractor is being used to retract the posterior superiorly based flap. Now this retractor, you retract the area just behind your mastoid cavity. From the sinodural angle, you can mark the area where the implant receiver stimulator can be placed. So now this is a thin implant, profile series implants. You don't have to drill a well in this. You have to make a shallow ramp of around 1 to 2 millimeter under the subperiosteal pocket. You can use a retractor. Then you can create a conduit or a channel, and then you can create a bony hook, which prevents the electrode array from bucking up. Okay, so this is the silicone implant which is placed in a trough, and you can see the whole area very well seen. Now even if you have a shallow trough, we still take, I'll be showing in the video how to fix this thin implants also later on. We just don't put the implant in the pocket, but we also take one periosteal stitch. After finishing your well and the cortical mastoid, now you can open the posterior tympanotomy. There are a lot of things which also I'll go to elaborate when I show you the video. The posterior tympanotomy, I don't know why many of them are scared to open through a posterior tympanotomy. It is one of the easiest. If you are a very good otologist, I think you should not be scared of the facial nerve. Very, very well, facial nerve is always there. It is not, you just have to find the facial nerve. And if you know how to find the facial nerve, you just have to delineate a chorda tympani, go between these two angles and enter the middle ear. So you have your incus here. This is going to be your base. This is going to be your base. This is going to be your facial nerve, and this is going to be your chorda tympani nerve. So most important, I always want, you can see your facial nerve here, but to create this base of the triangle is very important. So how will you create the base? From the tip of the incus up to the lateral canal, the distance, the same distance you carry inside the posterior canal wall. So keep on thinning the medial wall of the posterior canal wall. By doing so, you create a very large posterior tympanotomy. So your posterior tympanotomy is like a funnel and not a tunnel. Okay, remember this, you have to have a wide posterior tympanotomy. And doing so, you have to keep on thinning but not breaching the posterior wall. So these are the landmarks for the posterior tympanotomy. Superiorly, your short process. Posteromedially is the vertical segment of the facial nerve. Anterolaterally is the chorda tympana, and inferiorly is the chordofacial angle. So this area is an important conduit for your electrode to enter inside the middle. Okay, so this is what I was talking about, fixing the thin implants. Even though implant, you can put it inside the posterior superior flap, but still there are chances that the implant may migrate, the receiver stimulator may migrate. So in my video also, I'll show you how we take the stay sutures are taken to fix the implant under the flap. So there is already a suture taken underneath the flap. The other end of the suture is tied along the implant, and slowly the implant is pulled inside the posterior superior flap, and you can see the implant underneath the flap. After you have fixed the implant, now you have to expose the round window. Don't open the round window till the implant, because we don't want to open the scala tympana and keep it exposed outside for a longer period. So when you are handling your implant, you have to, that is a time you have to change your gloves, because your gloves are maybe, they may be blood or bone dust on your gloves. So at this stage, you will have to change your gloves and start looking now, exposing your round window. Round window may be sometimes completely covered with a soft tissue, or there may be a bony overhang. Superiorly, anteriorly, posteriorly, you may not be able to see the round window. Thus, there are various ways how you can expose the round window. So for that, you have to keep on thinning your bony canal. If you keep on thinning your bony canal, more and more exposure of round window can be done. And for this also, your facial nerve also has to be, you have to go right up to the facial nerve, then only you will be able to expose this round window. Okay, so this is after the overhang is removed, you have a very good exposure of your round window membrane. Again, if there is a soft tissue which is white in color and the round window is grayish in color, this is how you identify the round window membrane. Once you have identified the round window membrane, you can take an incision on the round window and spray your steroid. See that the steroid is not sprayed inside the cochlea, but just spray in the middle cavity. Okay, so this is the round window which is open. And now the electrode insertion is the tip of the electrode. There are many people who use an AOS forceps and guides the electrode tip up to the cochleostomy or up to the round window opening. But my method, as I have been learned by sir, I use my left hand. I see that the electrode goes inside the round window and then uses a AOS forceps. You will see in the video, and very slowly with very minimal force. Do not rush. They say it should take a minute for the implant to enter inside, but with our human hands, we will have tremors if you take 1 minute of time to insert inside. Okay, see that your array should not kink, and if you feel there is a resistance, partial insertion is better than forcing the implant beyond the point of resistance, because if you force your array, you will get tip rollovers. Okay, then after your electrode placement has been done, the round window opening has to be plugged with fat and fascia, and this prevents perilymph leakage or also prevents extrusion of the array. And the remaining array is coiled inside the mastoid cavity, and it is secured under the bony hook which you have created. After this, we need to, this is from the advanced bionic implants. So these are called as neural response imaging, and the cochlear is called as neural response telemetry. So it is the same thing. It is an intraoperative, non-invasive, objective measure of your neural function. But first it measures the impedances, and then it measures the integrity of each electrode. So this helps us to determine the auditory nerve is responsive. It provides a reassurance to us also and to the recipient and the family that the electrode array which we have placed inside the patient is working. And also it establishes a baseline and helps us in assisting in our future programming. So these are the how we have the responses which are seen here, and these are the very good N1P1, the very good responses which are seen on NRI. C-arm is a must. We all do C-arm. If you don't have a C-arm, but X-ray, so intra-op X-rays or intra-op C-arm is done to see whether your placement is correct. You may see a possible kinking. You may be seeing a kinked array. You can see a wrong entry. So if you see all this, they can be corrected at the same sitting and the patient doesn't have to undergo anesthesia next day. So it is very important for us to see, and especially so when you're doing a malformed cochlea, where your electrodes are likely to enter into the internal auditory meatus. Resuturing the flap, see that your flaps are resutured and your implant is completely covering this flap. You can see the implant here, which is covering the flap. You can see the implant here, which is completely covering the flap. So there is no chance of having an implant receiver stimulator extrusion if there is any infection later on in your post-operative period. And you can see the implant is very well seen away from the suture line. So your suture line is over here, where you and your implant is over here. So if you have a ear level processor, then it is not going to come in between your ear processor, and the receiver stimulator will not rub against your ear processor. Screen closure with subcuticular sutures. Okay, so this is your, I'll just come to the video back again. Not working. 1 minute. This video not. Okay. So I have already taken this all the previous incisions and all. I'm just started doing cortical mastorectomy, and you can see I'm delineating the sinus plate and the dural plate. Go beyond the sinus, which I told you, so that because this cavity is a small cavity, so I'm going beyond the sinus plate. I've already delineated the dural plate, going up to the mastoid tip. Okay, looking for the incus. Now you can see the incus being, you can see the short process of the incus. Okay, so you have your dural plate, you have a sinus plate, you have a mastoid tip, you have an incus here, and now I'm thinning the posterior canal wall. Keep on thinning the posterior canal wall so that it sometimes you may have to do a paper thinning of the posterior canal wall. Continuous irrigation to wash away the bony dust. Okay, and now here what I want to tell you is you thin out the posterior canal wall medially. And keep on looking with a larger burr, keep on thinning and identify the facial nerve. So now your facial nerve is going to lie. This is your short process of incus and this is your mastoid tip. Your facial nerve is going to lie in this line. Keep on continuously drilling along this line very patiently, very patiently. Use your diamond burr, use a large burr, don't use small burrs till you see the facial. Now you can see the facial coming here. Use now a smaller burr and identify the chorda tympani. It is very important to identify chorda tympani because you may inadvertently open the, you damage the annulus and open the external auditory canal, which is not advised at all. Okay, so keep on drilling at this region, thin out the area between this. Now you can see the facial very nicely, and you can see the chorda tympani. Okay, so this is your facial, this is your chorda tympani, this is your incus, and I'm drilling in this targeted area. Keep on using burrs. There is no which size of burrs. Just keep on using the burrs so that those burrs should not touch your nerves. I'm now underneath the facial nerve. I'm opening the facial recess. I'm just entering the middle ear now. Okay, you can now go up to the base of your triangle. You can just get a glimpse of the round window, but don't do anything there. Again, widen your posterior tympanotomy so that more illumination and more light can enter inside the middle ear cavity. Okay, you can see the round window there, but now this round window is not properly seen because it is covered with a soft tissue. Again, I'm thinning the posterior. You can see it is really a paper thin canal, but you should not breach the posterior canal. Okay, I'm drilling underneath the facial nerve so that I can very well expose the round window. Okay, now you can see the round window. There is a lot of soft tissue on the round window. I'm removing the soft tissue, but I am not doing anything at this time. I know where the round window is. I come back and place the implant. This is your silicone template. This is your conduit and this is your hook which has been made. Okay, this is a periosis stitch you take underneath your flap. The template helps us to know exactly the place where you can take the stitch. Now take the other end of your stitch and go around the implant. Secure with the second stitch. Now pull the needle end and pull the implant inside the pocket. Now the stitch which you have taken and the stitch you now close again. So now the implant is tucked underneath the flap and the sutures helps to keep the implant in place. Okay, so this is how we fix the implant. Now come back to the, after putting the implant, come back to your round window. You can see now the round window is completely covered with soft tissue. Very meticulously drill the overhang. Keep on removing the bone dust. See now here, your shaft should not have a shoulder. It should be a tapering because when you're doing your work around the round window, the shaft of the burr can cause heat, can dissipate the heat to the facial nerve, or it can rub against, may get a facial palsy. Again, the soft tissue, and you can now just get a glimpse of your round window membrane. Still the round window hole is not exposed. Again, very meticulously remove the overhang. These are done with a small burrs. Steroid solution is sprayed inside. Remove all the dust particle. See that there is no blood around in that area. So you're preventing any blood, bone, dust, or any pate entering the cochlea. Okay. Still, I think there is still more overhang.
Again, some issue, I guess.
They're joining in 1 minute. Dr. Sangeeta, you're audible. You can please continue.
Okay, so I just go back to this video where we had stopped. Okay, so I can just go back so you can. Okay, so I'm drilling the round window, and now you can see the well exposed round window. You take a 23 number needle and take an incision anteriorly. Okay, don't suck at this. You can suck at the hypotympanum. Video is not playing? No.
Doctor, just click on the video. It should be good. Yeah.
Yeah. Okay. Is it playing?
Now click again. You should. Yeah. No, it is freezing actually. The video is now frozen.
Yeah.
Can you just click on it? It is moving slowly.
It is not going smooth. It is going jhatka leke.
You can stop and share again, please, if possible, Doctor. Just share again, please.
Yeah. Okay. Can you see now? Hello?
We cannot see the presentation. Can see you.
You can see the video?
No, we are seeing you. Yes, we can see your video now.
Okay. So the incision has been taken and the round window opening you can see. Now the electrode array is, as I said, I'm using the electrode array. I wash the array with the steroid solution, and slowly with the left hand you direct the tip of the array up to your round window. You're sucking in the hypotympanum, and your array is just entering the round window. Then take your AOS forceps or automatic forceps and you hold the wing. These are half band electrodes. The electrodes are facing the incus, and very slowly the electrode is advanced inside the cochlea. Very minimal force. It's now very well gone inside. You take a soft tissue or fat which you had taken initially and plug this area so that you don't get a post-operative perilin fleek. The remaining electrode, you hook it under the bony hook which you have created. And the rest of the array is manipulated very gently inside the mastoid cavity. You can use some soft tissues to keep them in place. And that's the end of the surgery. The periosteal flap is sutured back, and you take skin sutures with subcuticular region. You do your C-arm to check the position, which I have told you in my previous steps. And thank you for this. And this is our Hinduja Hospital. It is a little place, but we are creating miracles of sound and speech in this area. And I'm always grateful to Dr. Milind Kirtane, who has held my hands and has led me to this journey of cochlear implant. Thank you very much.
Thank you, Dr. Sangeeta, for this very informative presentation on cochlear implants and with the latest updates too, including robotic surgery.
Okay, so there is a question which is, when to implant in post-meningitis and labyrinthitis patient. So if you are having a history of meningitis, you have to do an MRI and CT scan to see how much fibrosis is present. If there are basal turn fibrosis, then you have to go immediately to implant this patient because you have no time. Because if there is a complete fibrosis of the cochlea, then it is not possible to implant these children or adult. Okay, so post-meningitis labyrinthitis patient, you have to implant as soon as possible. Okay. If there are no more questions, thank you all again. I'm going to log out now.
Thank you very much, ma'am. It was a very excellent lecture, detailed, comprehensive, and it covered every aspect of, surgical and diagnostic aspect when we talk about precision in cochlear implant surgery. Thank you so much for joining us, ma'am.
All talk, there's a lot more to talk, but I had to just cover a surgical technique today. Okay. No, it's okay. No, it's okay.
Yeah.
For our next talk, it's my great pleasure to introduce Dr. Anagha Joshi, ma'am. Ma'am is professor in Department of ENT at LTMMC NGH Sion Hospital, Mumbai. She is also a consultant at HN Reliance Hospital and Joshi Clinic in Mumbai. She is the PG guide and mentor for MUHS Fellowship in Laryngology. She has 11 publications in international journals and 32 publications in national index journals. She has chapters in 8 ENT textbooks. She is the editor of Special Laryngology volume of International Journal of Head and Neck Surgery and has designed Joshi's stellar stent for laryngeal stenosis. She has also been the recipient of the prestigious Ralph Cooper Award in 41st MedCon in 2011. Her areas of interest are laryngology, endoscopic sinus surgery, and lateral skull base surgery. It's a great pleasure to have you with here today, ma'am. Thank you so much for joining us. We're looking forward to hear from you.
Thank you so much. First and foremost, I would like to congratulate the Women's AOI organization and the executive team, especially for doing such wonderful work and getting us all together on this platform. So let me start my presentation by sharing my screen. Audio optimizations are there. Share audio, optimize. Okay. Is my screen visible and am I audible?
I can hear you, but I think you have to share your screen.
I have shared. I have already shared my screen.
I'm seeing you.
Oh, is it? Stop share. Optimize video clip now. Optimize share sound. Okay. Can
you see now?
Can you see my screen?
No, not your screen.
Is it okay if I take this middle time as a filler to talk a little bit? Ma'am's topic is benign lesions of the vocal cord, in which we have trouble raising the voice. However, in light of what has happened in Calcutta and what the country is facing, I wish that all of us do raise our voice. We continue to do our work. We're still continuing our efforts of learning and getting together, but it's also very important for us to raise our voice when we see injustice. As of currently, the situation is that Section 144 has been imposed near RG Kar. 40 doctors who have protested against this have been transferred. So there are, attempts to kind of silence us, to break this protest, to sort of not get justice. It should not be so hard to conduct an investigation in which there are no clues. How come they're not talking about the phone? How come they're not talking about statements from colleagues and people known to the victim? But somehow it feels like, a massive outrage is needed. So for all our friends and colleagues in Kolkata, we want you to know that WI especially very passionately spearheading this movement, and we will all continue to write and post and join in whichever way we can. And we will also keep continuing our efforts of learning, and ma'am's screen has shared. So thanks for giving me this 1 minute to kind of express all this rage that's been inside me. Ma'am, over to you. Thank you so much.
So let me start my slideshow. I hope my first slide is visible to you.
Yes, we can see it now.
Yeah, thank you. Okay. So I'll be talking on benign vocal fold lesions. So mainly the common tendency is to, when you see a benign vocal fold lesion, you see it, you cut it and forget it. You feel it's just simple. You just have to chop it off. But do you get this result every time? So let us see what are the finer nuances when you are dealing with the benign vocal fold lesions. To begin with, we should know the laryngeal biomechanics and the specialized histology of the vocal folds. The vocal folds, the medial edge is the vibratory edge, and any affection of the medial edge significantly affects the voice. The superior surface is exposed to the inhaled chemicals, and the voice gets least affected when the superior surface is affected, unless the superficial, the SLP is involved. The amplitude of vibration is highest at the superior edge of the medial surface of the vocal fold, and it is most at the mid-membranous part. So this is the site where you usually get the development of the vocal nodules, that is the mid-membranous portion and the superior edge of the medial vibrating surface. You should also know the unique structure of the vocal folds, which was first described by Hirano in 1975. The vocal fold has a multi-layered structure with the superficial most is this epithelium, then is the superficial lamina propria, then is the vocal ligament, which is formed by the intermediate and the deep lamina propria and the muscle. So the superficial lamina propria, which is the ringke space, is the most vital for phonation. It is gelatinous, it has loose fibers which are made up of elastin and collagen, and has hyaluronic acid, decorin, fibromodulin, and fibronectin as the molecular structure. You should also know the body cover concept of the mucosal wave, that the cover is formed by the epithelium and the superficial lamina propria. The transition zone is formed by the intermediate and the deep layers of the lamina propria, and the body, which is formed by the vocalis muscle fibers. So the cover is pliable, elastic, and non-muscular, whereas the body is more stiff with active contractile properties. So what is a mucosal wave? It is a wave-like motion of the loose cover which occurs over the stiffer body. Any scar or growth will stiffen the cover layer and will affect the mucosal wave. So that is a normal mucosal wave which is seen. So the mucosal wave is a video. Okay. So what are the principles of phonomicrosurgery? One, and the most important, is the preservation of the lamina propria overlying the epithelium and the overlying epithelium. And the straight medial vocal fold edge should be maintained to decrease the glottic gap, and removal of any adynamic stiff epithelium which will improve the pliability of the vibration. So what will you do when you're before beginning any excision? First is to do a subepithelial infiltration with 1 in 10,000 saline adrenaline. This, what it does is that it increases the depth of the SLPs. It not only helps in vasoconstriction, but also helps it to differentiate the superficial and the deeper structures, so that if the lesion is attached to the ligament, you will get a donut sign. That is, the infiltration will go all around the lesion. Whereas if the lesion is superficial, then the without involvement of the vocal ligament, the lesion will be lifted up. It also causes hydrodissection. Within the stipulated time, it will be very difficult to talk about all the benign vocal fold lesions. So let's concentrate on the more important as well as the more commonly occurring lesions, which are the nodules, polyps, cysts, sulcus, and papillomas. We will look for the etiology, symptoms, management, appearance, and the prognosis of these individual lesions. So vocal fold nodules are caused by misuse and overuse, and they are the most commonly affected lesions that any of us would encounter. It's more common in boys than in girls, and in females than in males in the adulthood. It typically occurs at the junction of the anterior and the middle third of the membranous of the vocal folds, or the mid-membranous vocal fold. It gives an hourglass glottic closure. The mucosal wave is present or the least affected, but may be decreased. The vibratory amplitude may be decreased. So you can see that you will see a hourglass closure, that is a glottic gap anterior and posterior to the vocal nodules. Mucosal wave is present, but may be decreased if in larger nodules or well-formed nodules. So what is the pathogenesis? Is generally caused by a chronic vocal abuse, or for a vocal abuse or misuse for a long period. There is edema and hemorrhage in the submucosal space, hyalinization, hypoplasia of the epithelium, and a nodule formation. So what is the treatment? The mainstay of treatment is voice therapy. And also you need to change the lifestyle or cause behavioral or habit modification to decrease, not only decrease the nodules, but also for the recurrence of the nodules. Vocal hygiene also forms a mainstay in the voice therapy. Increase hydration, and most important is ask the patient to avoid throat clearing. What do you mean by throat clearing is khakarna. That if you ask the Hindi terminology for that. Surgery is very rarely required. I have also seen, it's not very common in India, but I have in abroad, there is a lot of tendency to inject intralesional steroids into the vocal nodules. Multiple sessions are required for this, but I personally don't use this methodology. What are vocal fold polyps? So they are typically unilateral. They are either pedunculated or broad-based, can be hemorrhagic or non-hemorrhagic. So you can see the first picture, it's a hemorrhagic vocal fold polyp, whereas here it is more of edematous mucosa within the polyp. So it generally occurs when there is a single episode of severe vocal fold abuse. There's acute vascular disruption, submucosal bleeding in the Ranke space, organization of the hyalinized trauma, and inflammatory changes and fibrosis. You can classify the polyps as edematous, vascular, myxoid, or hyaline. So hyaline fibrosis, when there is a lot of, in a long-standing polyp, where there is fibrosis within the polyp. Typically, the patient presents with hoarseness, breathiness, decrease in the dynamic range, and decrease vocal intensity. So typically, the voice is diplophonic. That is, you can hear two sounds because the vocal fold, there may be two or multiple zones created by the polyp. On video stroboscopy, you see an incomplete glottic closure in internet connection. There the vibratory pattern may not be affected, but there's diminution in the vibration at the site of the lesion. So you can see that the mucosal wave is present, but is decreased at the site of the buccal fold polyp. What is the role of stroboscope? There are many colleagues or younger colleagues who may ask, why do we actually need a stroboscope? In this is the rigid laryngoscopic picture. You can see that there's a very small polyp here, and there's hardly any phonatory gap. But the patient's voice was severely affected. So when there is a discrepancy in what you see on laryngoscopy and what is seen, what the patient's voice is, you can see here on stroboscopy, there is the mucosal wave is severely affected, that there is a sulcus in the opposite vocal fold, and there is a small polyp on the left side. So this is the importance of the stroboscopy, where you can prognosticate what could be the outcome of your surgery. You can give the prognosis as, you can give a guarded prognosis in this case. Also, you may have to talk to the patient regarding whether you would like to deal with the sulcus at the same sitting. So this is the importance of the stroboscopy. One is to diagnose the lesion. Two, it is to know also the depth of the lesion. And three, to give a prognosis to your surgery. So when you have a polyp, what is, you might have heard the terms of microflap excision or mini microflap excision. What do you mean by microflap excision? That is, you take a chordotomy incision just lateral to the polyp, that is at the base of the polyp. You elevate a flap, that is, you elevate the epithelium over the polyp. You remove the contents of the polyp. Many a times the polyp cannot be completely separated from the epithelium because it is not like a cyst lying separately within the SLP. So you remove the contents of the polyp and you redrape the mucosa and remove the excess mucosa. So what is done? Once you have made the chordotomy incision, elevate the epithelium of the polyp. Many a times this may not be possible if the polyp is severely adherent, but try to remove the contents of the polyp. You can see here that it is very important to save the infraglottic epithelium of the polyp. So once you have removed the polyp, the infraglottic epithelium is redraped. This is dexamethasone, which is injected at the base of the polyp, and you have to have a straight medial edge of the vocal fold after surgery. So this is the post-operative stroboscopy of the same patient, where this complete restoration of the mucosal wave. In some cases, you can remove the polyp as an isolated, like an isolated cyst. So you take a chordotomy incision at the base of the polyp. You separate the polyp from the underlying SLP, create a flap over the polyp, or the overlying epithelium is separated from the polyp. Hold the medial edge of the epithelium and excise the attachments of the polyp superiorly and inferiorly, or anteriorly and posteriorly. And completely excise the polyp from the underlying SLP and remove the polyp. What do you mean by mini microflap? So sometimes the polyp is completely adherent to the epithelium. You cannot raise a flap over the polyp. In those cases, once you have taken a chordotomy incision, excise the polyp right at its base. So this is a chordotomy incision has been made. The polyp is separated from the underlying SLP. And you just truncate the polyp at its base without damaging the underlying superficial lamina propria. What is the role of conservative treatment? It is to prevent the recurrence and progression of the polyp, as well as many a times patient has adopted some maladaptive compensatory habits so as to relieve this discomfort and relieve the patient of these compensatory habits and improve the surgical outcome. Intralesional injections can be done, but it requires repeated intralesional office-based laryngeal steroid injections, and it is really not recommended. What are vocal fold cysts? So they can be divided as epidermal cysts, which contain keratin and cholesterol, and they are basically congenital epithelial cell rests. They are covered by stratified squamous epithelium, whereas mucus retention cysts, they contain mucus and because of glandular obstruction. And they are found on the free edge of the vocal fold and covered with ciliated columnar epithelium. Vocal cyst on stroboscopy would look like a boat or a buoy bobbing over the waves because it is completely within the superficial lamina propria. It's something like a grape, which is a small grape, which would be placed in the superficial lamina propria. So if I
Hello, we are just having a little technical glitch again and hope it will be sorted out soon.
share screen करें परत गेला शेअरचा थांबतात ऑप्टिमाइज ना I'm very sorry about the interruption. Can you hear me now?
Yes, I can.
Yeah. So what do you do with the cyst? So if for a cyst, you typically require a microflap excision. For a cyst, I generally don't infiltrate because then it obscures the margins of the cyst from the rest of the SLP. To take a cordotomy incision, elevate the flap over the cyst. Separate the cyst from the underlying SLP. cut the attachments of the cyst anteriorly and posteriorly. And redrape the epithelium. Sorry, there was some, okay. And this the when you can remove the cyst in toto and redrape the epithelium. So what do you do when you encounter a sulcus? What exactly is the sulcus vocalis? It corresponds to a thin groove running along the length of the free edge of the vocal fold. Ford has classified sulcus as type 1, which is also called as a physiologic sulcus, where you see a longitudinal depression running along the membranous vocal fold. You have to keep in mind it has to be a membranous vocal fold and not the entire vocal fold that is not involved in cartilaginous part, because that is called as a pseudosulcus, which is seen in laryngopharyngeal reflux. So when you get a longitudinal depression along the entire membranous vocal fold, it may cause mild vocal dysfunction, which is type 1 sulcus, or which is also called as a physiologic sulcus. The mucosal wave is hardly affected and the voice is very rarely affected in such cases. Type 2 is sulcus virgatur, which extends along the membranous vocal folds and it extends to the vocal ligament. It causes disruption of the mucosal wave and can lead to moderate dysphonia. You can see that there's a sulcus on the, you can clearly see the sulcus on the left vocal fold, and the phonatory gap is typically spindle shaped. The mucosal wave is affected, the amplitude is decreased, and the phonatory gap is spindle shaped. In this snap picture, you can see bilateral sulcus in the membranous cords. And what is type 3 sulcus? Type 3 sulcus is also called as the focal pit, or also termed as a true sulcus. It is a deep pit-like focal indentation in the membranous vocal fold. There is a complete loss of SLP. There is severe disruption of the mucosal wave. Sometimes this pit can extend right till the muscle, and the patient has severe dysphonia. So what do you, how do you rate this voice? The patient, if you recognize that the sound is very high pitched. So in a sulcus, what happens is that it causes severe stiffness of the vocal fold. So because of the stiffness of the vocal fold, the pitch increases. But you need to differentiate it from pubophonia, where there is hardly any breathiness in the voice. In pubophonia, it's on Guzman stage, that is the compression of the larynx anteriorly and inferiorly, the sound will improve. That is, the pitch will lower down, which will not be in the case of sulcus. So the voice in sulcus is breathy, very strained, high pitched, and there can be frequent episodes of aphonia also. Many a times the sulcus may not be visible on laryngoscopy. When you find that the patient's voice is not matching with your stroboscopy findings, or you don't find anything on stroboscopy, you may actually need to do examination under anesthesia. And sometimes the sulcuses are hidden underneath the medial edge of the vocal fold, which is also called as the umbrella effect. So what do you do with sulcus? Earlier, what was done was fat implantation. That is, you take an incision just lateral to the sulcus after subepithelial infiltration of 1 in 10,000 of saline adrenaline. You lift the sulcus off from its attachment to the deeper vocal ligament or the muscle, and sort of create a pocket. Once you've elevated the sulcus completely, you create a pocket. And within this pocket, you implant a fat lobule, which may be taken from the thigh or from the cheek also. So you don't need a separate thigh incision. Once you have inserted the fat into the pocket, you take sutures with 6-0 Vicryl. You can additionally inject fat lateral to the like in the paraglottic space so as to augment the vocal folds. So this will close the glottic gap. I have deliberately not shown the suturing technique because one is takes a lot of time because it has to be very meticulous, and it is taken with 6-0 Vicryl with a small 5. The size of the needle has to be 5/8 circle with a 6-0 Vicryl. Now what is done is a Pontes technique where you take an incision lateral to the sulcus. You elevate the sulcus from its attachment. Here it was attached to the vocalis muscle, and you take vertical incisions either with either with laser or with cold instruments, that is a scissor. You take vertical incision or perpendicular incisions from this cordotomy incisions. This basically, it breaks the tension lines of the sulcus, and the epithelium then redrapes over these cuts that you have taken. The surgery, when you have done this, the procedure looks very ghastly, or many a times in the initial surgeries, I felt, oh, what have I done to the vocal folds? But to my surprise, it really gives a very good result. This is the preoperative stroboscopy of this patient. You can see very deep sulci with phonatory gap. And this is the post-operative stroboscopy of the same patient. You can see that this was after 6 weeks of surgery. You can see that the epithelium has redraped over these incisions that you have taken. You can see there is a lot of huskiness, breathiness, high-pitched voice, and roughness in her voice. This is the post-operative voice. So, in a sulcus, you may not give the prognosis of a very good voice, but yes, you have to explain to the patient that there will be improvement, but it will not give it may not be perfectly normal voice. There's another technique which is called as the LASR, that is a laser release of the sulci, which is described by Dr. Nupur. Here, instead of the incisions that you're taking with the cordotomy incision and the vertical incisions that you're taking with the cold instruments, you can take the same incisions with laser, which will give very good or similar results to the surgery. What do you do with recurrent respiratory papillomas? So basically, these are benign papillary squamous cell tumors caused by human papillomavirus 6 and 11. They have a tendency to recur. They may have an unpredictable course, and the management of this is challenging. So the hoarseness is the first symptom. Patient may have dyspnea and stridor, chronic cough. Sometimes patient just present with recurrent respiratory infections and failure to thrive. And there is a delay in diagnosis of the RRP because they are misdiagnosed as flu or asthma or vocal nodules. So, and it has been seen that the definitive diagnosis of RRP is made around a year after the initial symptoms. So they are typically exophytic, cauliflower-like presentation, and pinkish white in appearance. And on NBI, you see a central vessels around the central axis of each papillae. The goals of therapy is to cure the disease, one, but at least if you cannot cure the disease at the first sitting, you have to maintain the normal morphology and anatomy, optimize the voice quality, and decrease the distance spread of the disease. So there has to be a multi-pronged approach. So what are the principles of therapy? One is to avoid a tracheotomy because it causes the disruption of the normal mucosa and increases the risk of spread of the disease to the trachea and the subglottis. Many a times it seems very intimidating as to how the patient can be intubated when the papillomas are completely covering the glottal opening. But rest assured, the anesthetist can conveniently or easily introduce the endotracheal tube through the papillomas, because it is not a stenosis that you're dealing with. It is just the closure of the glottis with the papillomas. So your the tube can easily pass through the papillomas. So whenever the patient comes to you in stridor or respiratory distress with the in cases of papillomas, try to take the patient immediately to the operation theater for emergency debulking rather than do a tracheostomy and later take the patient. Patient can be it can be scored by a Durkee et al. But this is a little complicated scoring in the sense you have to mark all the sites of the papilloma as well as the size of the papilloma. So it helps in assessing the severity and the clinical course of the disease, and it's easier for communicating between the surgeons. There's an easier grading system which has been described by Dicker in 2006. One is grade 1 papillomas, where it can be either sessile, unifocal or multifocal. Grade 2 is exophytic papilloma, which is unifocal, and grade 3 is exophytic papilloma, which is multifocal. Treatment modalities, you can employ one or two or multiple modalities of treatment: laser, microdebrider, coablator, adjuvant therapy, or cold instruments. Typically, I use a microdebrider to begin with, and so it is convenient and it will excise the papillomas rapidly. It also has a suction channel, so the blood obscuring the field is the blood does not obscure the field. So first and foremost, you take a biopsy with forceps and send it for histopathology. It may not be done at every sitting, but you can do it at every third sitting of the surgery. So the microdebrider is the laryngeal microdebrider is used, where it has got two blades. One is the trichet blade and one is the skimmer blade. So for the initial debridement of the papillomas, you use a trichet blade. This is the papillomas being debrided from the ventricle. You can see that here if you see the external picture of what I'm doing, I have exposed the larynx with the Macintosh laryngoscope and secured it to the chest. And I'm using in my left hand, I'm using a camera, and in the right hand, the microdebrider. So this patient had tracheal papillomas as well. So it's easier with the endoscope and with the microdebrider blade to go into the trachea and distally as well, which may not be possible with the microlaryngoscope being fixed to expose the larynx. So these are the tracheal, the patient had extensive tracheal papillomas. You can use a mitomycin to after your surgery to decrease the granulations. This is a laser technique being used. Here you can use the laser as an AccuBlade, where the cordotomy incision is made with the laser. The papillomas are held with forceps, and subepithelial excision of the papillomas are done. So the laser is used as a cutting tool here. It can also be used as to ablate the base of the papillomas, where a defocused beam can be used to ablate the base of the papilloma. Here I have used a coablator. After removal of the papillomas with the debrider, I'm using the coablator to ablate the base of the papillomas. The coablator used here is not the routine tonsil adenoid wand. This is a LMW wand, that is a microlaryngeal wand, which has got a smaller tip and a smaller footprint. So it causes a small area of ablation. Sometimes you may need to use multimodality, multi-port technique. What do you mean by that? So this patient had come with a tracheostomy, had laryngeal papillomas, had tracheal papillomas. Cannot play the media. Okay, fine. 1 minute. Let me play it from the. देखा ना होता है? So this was the scopy after 3 sittings. I'll just escape from this and I'll. Screen sharing stop. Okay, anyway. Anyway, we'll go ahead with the presentation. So it's somehow the video was not playing. This is the video. This was a 2-year-old girl who came with extensive papillomas involving the larynx, the trachea. After removal of the laryngeal papillomas and removing the tracheal papillomas with a laryngeal bond, she had a tracheostomy as well. When she presented to us. So at the site of the tracheostomy, there was a huge bulk of the papilloma. So a different port of entry was used. That is, this I'm going through the tracheostomy site where the papillomas are debrided with the micro debrider. This is through the tracheostomy. After debriding the polyps, we need to ablate the base of the polyp. So the tracheal polyp, a diode laser was used to ablate the base of the polyps within the trachea. And a CO2 defocus beam was used to ablate the base in the larynx and the supraglottis. This case was extremely challenging because the patient, I mean, it was a 2-year-old child with the larynx and trachea being very narrow. It was very difficult to negotiate the instruments within her through the small spaces. And this was a large papilloma which was excised through the tracheostomy. This is after she required 3 settings of surgery. This was after this is at the 4th sitting. You can see that the papillomas have been completely excised with the vocal folds looking normal, the trachea looking normal. And at this point, the patient was decannulated. So you see that it's not just excising the papillomas completely, but it is also to preserve the underlying vocal fold and preservation of the vocal function of the patient. So this patient had come after once she had just come to meet me on Doctor's Day, and it was very gratifying to know that she also wanted to be a laryngologist like me. So it's really gratifying when patients come back to you while they are fine just to meet you. Cidofovir is used when the patients require more than 4 surgical procedures per year, when there is distal spread of the disease, when there is rapid regrowth of the papillomas. It prevents the viral replication and transcription. And so after debulking the papillomas, you inject the cidofovir intralesionally at the base of the papillomas and in the normal mucosa surrounding it. So this is a preoperative picture of the adult papilloma that I had showed you. So which had laryngeal as well as the tracheal papillomas, and this was the post-operative. So this patient required almost 5 to 6 sittings over a period of 2 to 3 years. And in this case, we had used cidofovir after excising the papilloma. I have deliberately not shown you any case where I have used CO2 laser for benign laryngeal lesions, for the very fact that this forum was meant for as to how anyone or younger ENT surgeons can replicate these procedures that we have performed. So when a CO2 laser has to be used, you have to understand that CO2 laser is not something that it's a tool which has to be carefully handled. Secondly, you have to have the best quality CO2 laser which causes the least amount of damage to the underlying microstructure architecture of the vocal fold. So the recommended CO2 laser would be one with a scanner system which has an AccuBlade, and so that it causes least thermal damage and improves the vocal outcome. If you do not have this, it's better not to use the laser and use a cold steel instead. It is the advantages of the CO2 laser. One is that it has the precision. It can deal with the hemorrhage as well when you are dealing with a larger papillomas and larger lesions of the vocal fold. The disadvantage is that it is significantly more costly than the conventional instrument. It has a learning curve, but you have to understand the dictum that no surgical technique is better than the individual using it. So this is a dictum that you should follow. Is many patients demand that we do the surgery with CO2 laser. It's better to use a good laser, and if you don't have that, not to use it at all, and use cold steel. So to conclude, one has to understand the etiopathogenesis of the laryngeal lesions and decide the line of management to prevent the occurrence and recurrence. Stroboscopy is essential for diagnosis and prognosis of various vocal fold lesions. Meticulous dissection and proper technique is mandatory. The choice of treatment should be based on pathology, expertise of the laryngologist, available equipments, and various patient factors. And first and foremost, you have to have the dictum as to do no harm. The laryngeal anatomy and the microstructure is as beautiful and delicate as this butterfly. You have to strive to keep it intact and functioning. Thank you so much for your patient listening and for the small glitches, technical glitches that we have had. Thank you. I can...
Thank you, Dr. Anaga, for this very comprehensive presentation, including the very challenging case and the patient who was so impressed by you that she wants to become a laryngologist. Yeah. That is, I think, one of the best messages that you conveyed.
Yeah. So I'll just deal with the questions that I have had. Which layer is the injection of hyaluronic acid given in injection laryngoplasty? So in injection laryngoplasty, it is one is that it has your depth of injection. 1 minute. Let me just share you one thing which did not get shared. Okay, you have to understand this. This is just to show you the size of the various layers that we're dealing with. So epithelium is 0.1 millimeter in thickness, that is 100 microns. Lamina propria is 1.5 millimeter, and the muscle is 6 millimeters by 16 to 18 millimeters. So when you're injecting into the vocal folds for injection laryngoplasty, let me show you a picture of the vocal folds. Okay, so when you're injecting, the point of injection has to be anterior to the vocal process, and it has to be lateral to the arcuate line. Okay, so your injection has to be somewhere, okay, I'm not able to see, but somewhere just lateral to this arcuate line and anterior to the vocal process, and it has to be at a depth of 3 to 5 millimeters. Okay, so it has to be beyond the superficial lamina propria. In cases of dysphonia, Vocal fold edges show white discoloration, but no phonatory gap. In cases of dysphonia, vocal fold edges shows white. Okay, white discoloration. Okay, it can be either leukoplakia or the vocal fold epithelium. Also, sometimes it can be fungal laryngitis that you have to rule out. Secondly, it can be keratotic plaques, hyperkeratosis, but generally hyperkeratosis may cause decrease in the mucosal wave. So if your mucosal wave is present and you have the whitish discoloration, it can be either leukoplakia or fungal laryngitis. Which layer of injection? Yeah. So when you're doing injection laryngoplasty, you don't inject into the SLP. You have to inject beyond the SLP, under the vocal ligament. What is the amount to be injected in vocal fold paralysis? Okay. So a preloaded syringe is available. Preloaded syringe of hyaluronic acid is available. That is a 1 ml syringe is available. Generally 1 ml is sufficient to medialize the vocal fold. Sometimes if the phonatory gap is very large, you may have to keep one more syringe handy just to inject further, because there is a possibility that the injected material can leak out of your injection site, or you may lose that injected material. So you may need to keep extra injection handy. Any other question? So do we move on to the next talk?
Yes, yes, we can
Yeah,
move on
thank
to the
you.
next talk. That'd be great. Dr. Shivali?
Good afternoon, everyone. So it's indeed a Sunday feast today. The valuable insights shared by our faculty has been truly enlightening. Thank you, WAIO, for giving me this platform. Thank you, Brada ma'am and Anaga ma'am, for giving me this opportunity and also helping me out with the PowerPoint presentation. Building upon the knowledge shared so far, I'd like to move forward with my talk. So, hi.
I'll request Abha ma'am to introduce Dr. Shivali by the time she gets her presentation up and running.
Yeah. Welcome, Dr. Shivali.
Thank you.
Dr. Shivali is Assistant Professor, LTMMC, GH Sion, Mumbai. She is the recipient of Dr. Harkut Award in Mentocon 2018. 6 publication in National Index Journal. Area of interest she has is endoscopic sinus surgery, otology, head and neck surgery. She has keen interest in medical teaching. So you can start, Dr. Shivali.
Good afternoon, everyone. So, hi, I'm Dr. Shivali Patekar, and my talk today is on endoscopic management of compromised airway. Compromised airway has many subtopics in it, but due to time constraints, we'll mainly talk about tracheal stenosis and management of bilateral vocal fold palsy. So the first case capsule here is of a 12-year-old male presenting with respiratory distress and stridor. Patient had a history of intubation for ARDS. We did an evaluation bronchoscopy for him. As you can see, the patient had grade 3 stenosis, membranous stenosis with the healthy tracheal rings. How do you manage such patients? Should it be an open surgery or a conservative management? Open surgery has its own pros and cons. Open surgery is a definitive treatment where we resect and anastomose the diseased area, but it's a supramajor case. So here, if the patient has any morbid conditions associated, patient may not be able to tolerate such surgeries. Patient has a longer hospital stay, and also intraoperative and postoperative morbidity also increases in such conditions. So conservative management, as compared to this, conservative management has a lesser hospital stay. The procedure can be performed frequently, but the patient needs regular follow-up. As they say, one size doesn't fit all. We have to carefully select the patients. So we have a patient selection criteria here, where tracheal stenosis of grade 1 and grade 2, single site involvement, a short segment stenosis that is of less than 2 tracheal rings. In few selective cases of grade 3 or early immature stenosis, where it is soft, dilatable, or it has a membranous stenosis. And of course, the patient should have healthy tracheal rings. The options in endoscopic management of tracheal stenosis, first is the Shapshay incisions or the radial incisions given. Second is the balloon dilatation. Most preferred is the airway balloon dilatation. Third is the adjuvant treatment, that is local application of mitomycin C and injection triamcinolone. Fourth is the bougie dilatation, which is an alternative to airway balloon dilatation. Now in this patient, first step was the Shapshay incisions. So in 1987, Professor Shapshay had first introduced this incisions in 5 patients of tracheal stenosis and subglottic stenosis, where radial incisions were given with the help of CO2 laser. The incisions were given at 12 o'clock, 7 and 5. It is similar to Mercedes-Benz logo, hence also called as Mercedes-Benz incision. Here we have given this. Here is the video of the similar patient. We have given the incisions. Initially, an emelscopic sickle knife was used to cut the incision, cut the narrowing. Later, an emelscopic side knife, the sharper part of the side knife, was used to deepen the incision. The second step in the management is the balloon dilatation. The preferred one at our institution is the airway balloon dilatation. So the airway balloons are available in various sizes. So this balloon is insufflated with normal saline, 8 to 10 centimeter of water. And this is the video, the balloon being inserted at the area of narrowing. It is then insufflated with normal saline. And placed in the area of narrowing for around 30 seconds to 1 minute. The third step is the adjuvant treatment. First is local application of mitomycin C. So here we use nasal endoscopic patty, which is cut into 1 by 1 centimeter with a thread attached to it. It is infused in in mitomycin, concentration being 2 mg in 10 cc of saline, and is placed locally with the help of a crocodile forceps locally in the area of narrowing. This is placed for around 2 minutes, followed by a normal saline patty to clean up the area. Second is local application of injection triamcinolone. Here we use a scalp vein needle, a 26 number scalp vein needle. So the flanges of the scalp vein needle are to be customized. The one part of the flange is to be cut. The second is to be cut short enough so that it is held by a crocodile forceps, emelscopic crocodile forceps, and is injected locally. Fourth is the bougie dilatation. This is generally to be avoided. It's a cheaper alternative to the airway balloons, but it causes tractional trauma to the mucosa, not just to the area of narrowing, but also to the healthy tracheal mucosa. So it's generally to be avoided. Here, what we can do is serial dilatation from the number of 18 till up to 32 number bougie. So this patient, after the 3 steps of management, the grade 3 stenosis had improved to grade 1 or almost normal airway diameter. There was another patient This is a video of another patient with grade 2 tracheal stenosis. Similar procedure of Shapshay incision, airway balloon dilatation, followed by adjuvant treatment was given to this patient. Immediate after the procedure, the airway had widened. It was grade 1 to almost normal airway diameter. The same procedure, the same patient underwent a scopy after a week. As you can see, it had improved significantly. As I mentioned earlier, these patients need a regular follow-up. So this follow-up scopy is to be done after a week, 7 to 10 days after the first procedure. If needed, serial dilatations can be done in such cases. 2 to 3 settings can be done. These patients are then started on steroid nebulization or saline with adrenaline nebulization. This patient are also on discharge. These patients are also given a pink slip which mentions the name and the diagnosis of the patient, and as well as mentioned over there that in case of respiratory distress, refer this patient to ward 3. That's our ENT ward. And we also give a contact number of a doctor so that there is no delay in treatment of these patients. There's a proforma that we have in our institute, that's the laryngotracheal stenosis proforma. Apart from our demographic data, we also mention the symptoms of the patient. There's bronchoscopy details have been mentioned in this proforma, where you mention the site, the grade, the type of stenosis, whether it is hard, soft, dilatable. If the patient is to be subjected for an open surgery, the distance from vocal cord, distance from the stoma, the condition of subglottis also plays an important role. So those all details are also filled in this proforma. So endoscopic management, yes, is a potential alternative or an adjunct to open surgery. Coming to the next case, there is a 40-year-old female presenting with respiratory distress, history of total thyroidectomy done 10 days back. A rigid laryngoscopy was done which showed bilateral vocal cord palsy. This was the video of the patient. So the patient has vocal cord palsy, bilateral abductor cord palsy with with inadequate chink. This patient was then subjected to an evaluation scopy. This is the Lidholm's false cord retractor to look for posterior glottic stenosis, if any. Another thing that we should do is to palpate for the cricoarytenoid joint fixation. This patient underwent a Kashima's chordotomy later. So primary objective of bilateral vocal cord palsy is to improve the ventilation of the patient. It can be done externally by a tracheostomy, but if there are facilities available, endoscopic laser chordotomy is the preferred option. Kashima had first introduced this lateralization procedure, where you can see the vocal fold is cut transversely, just in front of just anterior to the vocal process. We have to avoid injury to the vocal process. CO2 lasers are preferred in these cases. Here, a CO2 diode laser has been used. CO2 lasers have an advantage of better hemostasis, minimum tissue handling, as well as more precision. This procedure was done, as you can see, there's no endotracheal tube inserted. So it was done under intermittent apnea technique, where you suspend the laryngoscope, we intubate the patient, we ventilate the patient, then remove the endotracheal tube. We get an apnea time of around 2 to 3 minutes, depending upon the patient's condition, and you continue with the cuts. Again, you intubate the patient.
It's finishing.
So the lateral extent of the Kashima here, if you can see, is the reaching up to the inner perichondrium of the thyroid cartilage. You can see there is a suction tip which is also introduced along with the laser to suck out the smoke for better visualization. So the end point of Kashima is a bleeding seen from the inner perichondrium of the thyroid cartilage. As you can see in the video, the end point is the bleeding site. So in this patient, preoperative, there was a bilateral cord palsy. Chink was inadequate. There was an evaluation scopy done to rule out posterior glottic stenosis. There was to look for cricoarytenoid joint fixation. Patient underwent Kashima's cordotomy, a wedge-shaped defect to improve the chink. Patient at present has a chink, adequate chink, serviceable voice with no history of aspiration as well. So as an airway surgeon, yes, there are significant challenges in not only in evaluating and treatment, but also in planning and selecting patients and selecting the patients. In most of the acute airway emergencies, tracheostomy is the preferred option, but it's not a definitive treatment. So hence, tracheostomy also comes with a social stigma of a tube around the neck. Hence, the surgical intervention is important. Endoscopic management offers a precise, if patient patient selection is proper, it offers a better management. There is better quality of life also given to such patients. Thank you.
Thank you, Dr. Shivali, for a very nice presentation and very informative presentation with all practical tips. Thank you very much. You could hear me?
I think Dr. Kalpana is back now. She was away due to an emergency.
Yes. Thank you, Dr. Sharmila. Okay, today has been the beginning, first masterclass today. We're looking forward to many, many more. Thanks, Antor. Thanks, Dr. Sharmila. Thanks, Dr. Renuka Bradut. Thanks to all the speakers indeed. You know, Dr. Anaga, Dr. Sujata, Dr. Shivali. Did I miss anybody?
Dr. Sangeeta.
Dr. Sangeeta, yeah. Thank you all. Excellent talks indeed. And all of you are the biggie wiggies of Mumbai city. And really, thanks. Thanks a ton. We appreciate all your efforts and the time. And thank you once again. Thank you, executive. Thank you.
Dr. Renuka, we can't hear you. I think you're muted.
Can you hear me now?
Yes.
Yes.
I'd like to say a big thank you to Dr. Sharmila Sondhi and the entire team of WAOI. Thank you for giving us this opportunity. And I'd also like to apologize for the fact that there was a break in internet connection in between. We did try our best to, boost the internet previously, do a trial run. So from our point of view, we tried our best, but technology will be technology and unpredictable. So thank you once again for the opportunity. And on behalf of the ENT department of Sion Hospital, I'd also like to thank Dr. Sujata and Dr. Sangeeta for giving their precious time for this event.
Thank you so much, Dr. Renuka. I really appreciate. Thanks a ton. And another thanks for putting up WA on your background. Thank you.
Right. Okay.
Yeah, so it's our platform is like on the lighter notes, like a Kapil show, So we are honored to have people like you. And the time will come that people seek us, to come to this platform. Let's hope.
Of course, of course.
Thank you.
And we hope to grow in stature and have a presence on the global platform too someday.
Yes, touch wood.
Yes.
Thank you, ma'am.
Thank you all once again. Thank you.
Thank you, everyone. Thank you, Entor. Thank you,
Thank
Dr.
you,
Renuka Bradwani.
team
Thank you,
Renuka
Dr.
Bradwani.
Let's keep continuing the movement. Let us support all the doctors in the community and let's move on. Despite whatever Section 144, this, that, let us fight for justice. Let us fight for safety. Thank you all.
And I'd like